All right, folks, we're going to give it another minute or two and then we'll get started with Simwars. Just a reminder, if folks could just keep their video off and then select the hide non-video participants button, that'll be great. We can just kind of keep our screens nice and clear. Sharon's one of our judges, so Sharon, you're more than welcome to keep your video on if you want.
I don't know how to do that. If you can tell me one more time though, because that would be great. Because at least it gets it'll make everyone who's talking bigger.
Yeah, so in the top right-hand corner, you'll see three little buttons. If you click that, there should be a button to hide non-video participants.
So I have a view button up top in the right hand corner.
That works. So Chris, what do you think? Should we get started?
Yeah, I think so.
All right. Okay. So welcome everyone to 2021 SAEM Resident Sim Wars. As best you know, this is a little bit different than the way we usually run things. So thanks for your patience and flexibility and working with us for this new virtual format. Hopefully this is the last time we have to do a Sim Wars virtually, and next time we'll all get to be together again. Just a reminder, in the top of your screen, if you click the view button, you can hide non-video participants. And for the teams that are competing, for the judges, for those that need to have their videos on, we'll let you know when it's time to turn your videos on. For everyone else, if you could just keep your videos off, that'll keep our screens nice and clear. So Simwars, the objectives of Simwars, for those of you that haven't actually been to a Simwars event before, is to engage learners using simulation and competitive resuscitative learning. That's kind of a phrase that we coined. I think it sums up Simwars pretty well. And to demonstrate the application of simulation to improve communication, teamwork, and medical decision-making. And more importantly, it's to increase inter-residency collegiality and have fun. Just a warning, this isn't your traditional simulation that we all know and love. This isn't a warm, fuzzy, coddling learning environment. This is a competition. It may be a little bit more like this. So I just want to give a shout out to the Simwars creators, Dr. Andy Godwin and Dr. Haru Okuda and Dr. Scott Weingart. Really founded Simwars, and Simwars has been around for many, many years. We've done it all across the United States. We have a Simwars case book that you can get. I think it's on Amazon now. If you want to get a Simwars program off the ground in your shop, this is a great resource. My name's Scott Goldberg. I'm up here in Boston, Massachusetts. Chris Sampson's with me, who's down in Missouri. And just wanted to thank all of our sponsors for making Simwars possible. The Simulation Academy, of course, RAMS, SimVRX, Beeline Medical, who does a lot of our audio-visual, and Camels, who is supporting our finale, which we're really excited about. It's going to be a really good time. I also, of course, want to thank the Simwars team, everybody who contributed to writing cases and putting on this, what I think is going to be a pretty incredible show for you guys today. And thank you for being here. This is a big commitment of your time, and hopefully we can get something out of it together. I also want to thank the teams, of course. And today we have competing with us Stanford, Washington, St. Louis, University of Florida, Jacksonville, Cleveland Clinic, Akron, Jacobi Montefiore, University of Texas Southwestern, Jackson Memorial, University of Miami, and NYU Bellevue. And unfortunately, since everyone's muted, the teams will just have to kind of let the applause ring through their ears. So for the teams that are competing, these are the brackets. Simwars is a single elimination competition. For the preliminary rounds, each team will face off against one other team in the same case. The winner will move on to the semifinals, and then there'll be a finals round as well. This is the order that you'll all be going. And for the competitors, you should have received an email with this list as well. For those teams that make it into the finals, we'll give some real-time instructions as we get there, but just kind of a heads up what's going to come down the line. For the two teams that do make it to the finals are going to be live. We're going to actually have you jump off of this meeting and jump onto a new Zoom link that we're going to send you when the time comes. And if you come out victorious, you'll get your name on our illustrious Simwars plaque. Congratulations to the 2020 ASEP Simwars winners, Jacobi, who are back again to defend their championship. And last year, SAEM was canceled, so that nameplate will, we should put like a little COVID sign up there or something, you know, in remembrance of. We'll just ask the judges to turn their videos on. Dr. Jane Kim and Dr. Sharon Griswold are joining us from Kings County Downstate and Penn State Health, respectively. So thank you guys so much for joining us today. And for each one of the cases, we're going to have one of the case writers come in as the third judge. We have Dr. Tim Cobalt, Pedro Barbieri, Michael Falk, Sarah Hawk, Heidi Bear, Nicole Elliott, and Mike Cassara is going to be joining us for the finals. So thank you all in advance for being with us, and really thank you all for such incredible hard work in putting these cases together. They're awesome. So after each case, there's going to be a debrief where we're going to focus on some teaching pearls, give a little bit of feedback, and we're focusing really on teamwork and communication and clinical decision making. These cases are kind of unique. This is a different format from your traditional Simwars. So the learning objectives of each case are going to be a little different depending on the case, and we'll talk through what those learning objectives are as we get there. After the judges debrief, you all, the audience at home, is going to decide the winner. We'll put this QR code up after each case, and you can just use your smartphone to go to a link that this will bring you to, and you'll be able to vote for the winner. The winner will move on to the next round. For the finals, the judges are going to vote and declare our Simwars champion. I encourage you to use our hashtag Simwars, EMSimwars, SAEM21, and our Twitter handle is @EMSimwars. So with that, we will get underway. Our first case of the day is going to be Stanford and Washington St. Louis. So we'll ask Stanford and Washington St. Louis to turn on their screens. And Dr. Tim Cobalt is going to bring us in. So Tim, you want to just lay the groundwork for us? What are we about to see?
Okay, so hi, I'm Tim Cobalt from University of Missouri. I'm excited to show you the video from this case. This is perhaps the most virtual of all the cases because it's happening totally in virtual reality. So my thanks to Dr. Ryan Rivera and CIMEX for allowing us to use their platform to run this case that Washington University and St. Louis and Stanford are doing. You'll see that the participants are all wearing a VR headset. And so they're actually all four of them together in VR, where the case is happening entirely. They're, doing the assessments, listening to the heart sounds, interacting with the patients, and putting in orders and giving meds and running resuscitation all within VR. They're all kind of located together physically, so they can see each other and have their own avatars. They're just kind of a floating head and hands. And then the case is being run by a moderator, which is actually Dr. Rivera from SIMX, running it in person at Stanford and remotely for the Washington University crew. So I think, the case ended up taking a little bit longer. It's about 20 minutes long, so we've edited it down for time. So there'll be some cuts as they're doing, parts of the resuscitation, but it'll be cool. We'll have both the view of the learners, how they look like in the headsets, and what they're seeing in third person and first person views throughout the case. So it'll be interesting to see and a little bit different than usual. So I hope you enjoy it.
All righty. And Stanford is up first. And away we go.
Scott, we lost our sound. Sorry, we're working on the sound.
Can people not hear? Is the sound not working?
No sound.
All right.
Yeah, we can hear.
Yeah, no sound.
Okay, well, let me try that again. I apologize. How about,
All right, hello, I'm Dr. Cohen. What brings you here today?
I was out jogging today, like usual, and about 10 minutes into my run, my chest started to hurt and I felt out of breath.
All right, and then let's just assign roles. So, Christine, I would like you to be the tech. Nicole, I would like you to assess the patient. Okay. And then Carl, can you be the nurse? I'd like you to put in an IV. Christine, can you put patient on the monitor? And Christine, can we also get an EKG? And then Nicole, will you get further history, please?
Yep.
I'm walking over.
Patients on the monitor, the vitals currently are heart rate of 112, blood pressure of 109 over 63,
right.
with a map of 78. And
And do you have a pulse ox?
Oh, I feel lightheaded.
try to figure out this. I found the
Can you get like past medical history and all the details?
My name is Dr. Prendergast, so we're part of the whole team taking care of you today. Has this ever happened to you before?
Can we also get a finger
No.
stick
Yeah,
Yep.
working on that right
by
now.
Carl?
Okay.
Please.
And do you have any other medical problems,
that
or do you
right
have a
now.
history of any surgeries in the past?
We just lost our pulse ox.
No.
Okay.
Last week I had a cough, but I've been feeling back to normal since yesterday.
Okay, so cough about a week ago. Okay, any medications?
Yes.
Any medications you take?
No.
Okay.
So he's statting his O2 size going down. Can we put him on some nasal cannula, please? Christine, can you do that?
Yeah,
And
I'm
then
not okay. And any pain anywhere, sir? seeing a nasal cannula, but we have
It
a
hurts on the left side.
left side of your chest. non-rebreather and a BVM.
Okay, I'm gonna take a quick listen here, okay?
Sir, when did this start?
Oh, here.
I was out jogging today, like usual, and
What, the
about 10 minutes
stethoscope
into my
again?
run,
Yes,
My chest started to hurt and I felt out of breath. About an hour ago.
Does it still hurt? Sir?
Yes.
And how old are you?
I'm 45.
Okay, have you been around anyone who has COVID-19?
No.
Okay. Can we also,
Pulse ox is on, and oxygen nasal cannula is at, it looks like 1.5 or 2, I can't really tell, and now setting 94.
how much oxygen do we have?
I think it's 1.5 or 2, but it's kind of blurry, so I can't see.
Okay, so regular rate rhythm, lung sounds bilaterally.
This is not easy.
And then can we look for any leg swelling, any like DVT risk factors? Right now, the things I'm thinking about are some kind of ACS, a STEMI, a pulmonary embolism, COVID. Can we also get a chest x-ray, please?
I'm going to put in some labs here. So, CDC, chemistry,
Troponin, COVID-19, if that's available.
Hey Ryan,
ENP.
have my screen flash.
And then Nicole, if we don't have an EKG, do we have a bedside ultrasound?
We do, I have
Bedside
one.
ultrasound out here.
Okay, let's have you step to the side.
Is there a way for me to show? Can you tell me what you see? Okay, so hypodynamic, let's do you here. Hypo or hyper? I'm trying to look, but I can't see that. Can you see? Not very well. What does the IBC look like? I don't know if we have IBC, let's see.
so I believe I ordered the labs.
So I don't see any character. Okay, guys, so now he's at an 83%. So now 84, so can we get RT on board, and can we also get a VBG?
Okay, I have an EKG. It looks like
Nicole, can you put him on some what do we have, the highest thing that we have? Can we do a non-rebreather mask, if that's all we have? Yes.
EKG looks like sinus tachycardia. I don't see any obvious ST segment changes. He does have some sort of.
We put him on oxygen first, please.
Yes.
Thank you.
Looks like he might have a dilated RV.
I don't know if you guys have.
Where is the extra oxygen? And then can we call respiratory therapy, please?
Yep, we'll have to get on the phone to do that.
So he does have,
How do you turn up the oxygen? Does anybody?
yeah, and then he has like T-weight inversion in 3. Oh, and then he also has Q in 3.
Yeah, so he has evidence of brave heart strain on the bedside echo.
Okay, so at this, okay guys, now he's hypotensive, so what I need is, can we get some, does he seem volume up or volume down or bulimic?
Chest X-ray looks normal.
Alright, so at this point, why don't we start with giving him 500 cc's of fluids. Carl, can you do that for me, please?
I'm really scared, doctor. Am I okay?
His pH is.
He's going down to 82.
Okay, because I'm trying to put him on a non-rebreather at 15. Does anybody know how to hook this up?
And then can we
Okay,
call,
you wanna do it?
I don't know if
Yeah,
RT exists here, guys, so right now he's hypotensive, and
I
then,
can't breathe.
okay, sir.
Here.
Can we also pre-oxygenate him?
Oops.
Oh,
Sorry.
Oh,
Nicole?
I'm starting to feel really lightheaded.
can you get stuff ready for intubation in case
So
we need it?
We need to
his
get him on a
D-dimer is
non-rebreather.
3,400.
Yep, have a non-rebreather.
Okay, so he has an elevated D-dimer. Do you have his COVID back?
I don't. It's not.
Let me try it here.
Okay.
His trope
Cords
is
in there.
0.37.
Okay. So right now, he could easily be having a PE with right heart strain. Let me know if you have any other thoughts.
Yeah, that sounds.
Yeah, based on the bedside echo, lung sliding bilaterally, clear breath sounds, more, I think our number one difference right now is PE.
So do we want to try a little bit of fluid?
Yeah, let's just try a little bit. The other thing is he could have COVID. Can someone sit him up?
Yep.
And then let's check for a pulse. Is blood pressure running every 5 minutes?
I don't have pulses.
No pulse?
No pulse.
All right, well then let's begin compressions. Christine?
The nurse will do compressions for you.
All right, I'm turning on the defib and I have the.
Resume compressions, please.
Okay, starting CPR.
All right, and then
Okay, I've got TPA IV goals.
All right, let's give the TPA. How much is it? Because I gave 500 milligrams last time. Is it a gram? Carl?
It's usually 50.
Okay, 50.
Is what I have here.
Okay, sounds good.
Okay.
All right, can I get updates from everyone?
Yep, I will need a ventilator and then someone to take over bagging while I set up for intubation.
I will take over bagging for you, and I do not see a ventilator
Okay, TPA again.
anywhere here, so I'll just bag for you.
We can just bag after
Yep.
the shoot.
All right, but we still need someone to keep time.
I think TPA again.
Okay.
All right, I'm still keeping time. We have 1 minute until 4 minutes are up into the code.
Okay, so can we also get the epi drawn? Actually, Nicole, if we don't have enough people to hold while you bag, let's just bag the patient. Okay, because we need someone to drop the epi. Carl?
Yeah.
I'm ready to go.
Epi in the code card, and to confirm TPA has been given.
I saw the syringe like empty.
Is it over there?
Yeah.
He gave it. He gave
You gave it?
TPA.
Okay. Gave TPA. He's persistently been in PEA arrest. We did have high suspicion for PE, so we gave the TPA, so I think that we should continue for at least another, like, I believe 20 to 30 minutes to make sure that the TPA does get, placed throughout his body. If anyone has any other ideas, I'm very open to them. All right.
And then we'll do a pulse check.
Thank you.
The epi's in. Nicole, you're still bagging.
And does anyone, Carl, do you want to look for any like free fluid in the right upper quadrant?
Yeah, I did.
I did
You
an
did,
initial pass
nothing?
as well, no fluid.
Okay, and then Christine, let us know when it's time.
There's still nothing.
All right, we can do a pulse check now and stop here.
Stopping CPR.
Okay, the rhythm is still nothing.
And
So
still have no pulse.
resume
Please
Oh,
compressions.
yes, yes.
Resume compressions, please.
All right. So I think that's probably a good place to stop. Y'all
Okay,
can
starting
take off your
CPR.
headsets.
All right, so the judges are going to do about a 5-minute debrief, and Drs. Griswold, Kim, and Cobalt, your time starts now.
Hi guys, this is Jane Kim. It's so nice to meet everyone, and especially the Stanford team. What a great job. Can I speak to one representative from the Stanford team, maybe the team leader? I'm so curious as to know how this all felt for you, because just watching it looked super crazy, like this bubblehead with like gloves floating around. I just wanted to hear what it was like.
So I guess to begin, one thing is I have -9 vision. And so I was team leader because I hardly could see out of my VR because I literally couldn't do things and I had my glasses on. So I had to like close one eye. I know that's like, doesn't matter, but I had to close one eye in order to do it so that I could see something out of one eye. It was also very hard because everyone was like ahead, but I couldn't see who it was. So normally in a code, you can say, Carl, do this, then he does that. And I hadn't memorized what color everyone was. So like when someone moved from somewhere to somewhere, it was very difficult. We didn't fully, like, it's easy to say, oh, they're hypoxic, put oxygen on, but like the person, so Christine was doing oxygen and her VR set stopped working. So she ended up going into the abyss and she was supposed to do all of that. So it was very like chaotic because we didn't know, I mean, that is not how a coach be run, but I mean, I think the virtual reality part of it made it extremely difficult given like we had that technical difficulty. Nicole was trying to put the oxygen on, it wasn't working. It kept falling off.
And I was 8 months pregnant and the oxygen was on the ground and I had to like reach down and get it.
And then I think you guys
like, oh, this is really
didn't
hard.
see a lot of the part where actually like once like Christine came back in and we kind of got a handle on the virtual reality, like the whole 5 minutes of the CPR, like I feel like we actually got it down decently well. We called for ECMO, we did a bunch of things and like pushed all these drugs, but like no one saw that part. But yeah, it was not your average code, because it was very difficult to communicate when you can't see the person.
Yeah, obviously, I'd love to just spend the last bit of my time saying, yeah, that looked super crazy. And knowing what technical difficulties you guys had, that was amazing job. I really wanted to emphasize you immediately assigned roles and called everyone by name. And I love that closed loop communication. You told people to do things, especially by their name, like Carl, do this, or so-and-so do this. And I think that was super important, especially when you couldn't see what was going on. So major kudos to you. I'm going to hand it off to Dr. Griswold.
I would echo what Jane said. And again, normally we'd want you guys to spend a lot of time talk about the case. Obviously this is case of a massive PE. We think about COVID all the time because we can't think about anything else, right? And so I was amazed by how you guys as a team did manage things. But tell us a little bit, because this is so different from a VR perspective and managing the case. What kind of learning, like how do you think this is different, and how do you really see this as being a useful learning tool, helping or hurting your learning? Is that Carl coming in from the side there?
Yeah.
Awesome. That's the first time you've made the camera, Carl. So.
Sorry.
Okay.
I think the VR is really helpful in the sense that it really, normally when we run a code, there's a lot of nursing staff and ancillary staff that are doing a lot of the tasks that, putting on the oxygen, getting everything set up. And we have pharmacists. We're very lucky that we have a lot of resources to do a lot of those things. So it's easy to forget, all those individual tasks that are not just ordering the medications and thinking about them, but actually administering them, getting them out of the Pyxis, doing all of those things that I think we take for granted in a code situation. And like Sophie said, I think, communication is one thing, just speaking to people. But I think particularly if you have a good team that you've worked with a lot, there's a lot of unspoken communication, sort of facial expressions, some of that body language, and actually seeing what people are doing that you kind of lose in the VR setting, right? If you're just a floating head, you can't see somebody, what they're looking at or how they're acting particularly. It kind of removes a lot of those things. So I think from that perspective, it's challenging, but it makes you appreciate that there's a lot of things that you don't normally think about regularly, that are just sort of taken for granted when you're communicating with your team that you kind of lose in that setting.
That's great. I mean, I think it was amazing to watch. I can't imagine how difficult it was. We have like 0 seconds left, but I want Dr. Cobalt to be able to say something in this and join in. But thank you guys for participating. Really appreciate it. Love the view too.
Yeah, I think you guys did a nice job. I mean, obviously it's challenging, and we gave you roles that you wouldn't necessarily do typically during the code, right? I think Carl immediately gets a nursing role while watching the video. You're like, Carl, you're the nurse now, and it's like, oh no, here's the role I'm not really qualified for, right? Like me as a physician, like I'm definitely not qualified for that role, right? But because you guys are having to both order, it's hard to tell from the video, but they're having to order the medication and then pull the medication and administer it. They're having to put the oxygen on and do it. So they're having to do all of the roles simultaneously. So I think you guys did a really nice job with kind of limited orientation doing this. And then, I think one of the cool parts of the case is like, how do you confirm the diagnosis of PE in the case? Like when you guys ran it, how did you decide this is a PE?
I mean, on the ultrasound, I was struggling a little bit with like every time I let go of it, it kept going back. Every time I tried to look away, I realized it had fallen out of my hand and it would come off the screen. But I think the only really like tools we had available to us, I mean, I didn't actually get a chance to look at the screen because in terms of imaging, but there certainly wasn't time to get him to further imaging. And you only had you only had parasternal long view on the ultrasound. So you only could see the dilated RV on that. And other than that, we had the evidence that we had clear breath sounds bilaterally, lung sliding
And we had the
bilaterally.
EKG. I mean, it was like, in this case, it was either, I mean, I kind of said out loud, but like, it was also, you know, this, you know, cause, it's like in a sim. So, I mean, PE was very high on my list, given that he was young, otherwise healthy. His EKG didn't look like a STEMI. He didn't have the S1, but he had Q3, T3. And I was like, oh, well, this is classic. So like immediately I thought of PE, but you know, I didn't just want to give him lytics right away. I wanted to like kind of get a little bit more before I just gave the lytics. But I mean, I think we gave them fairly quickly. When he coded, it was like, oh, we should probably give him some lytics.
Yeah, and that's the way it's kind of
Alright,
designed.
guys.
But you add the ultrasound in, and that kind of shows you the dilated RV. So, but you guys nailed the diagnosis. So good job.
And the ultrasound was also really hard to interpret. Like, at least for me, I like could hardly see, so that they had to like tell me the vitals and stuff. I was like, hey guys, tell me what you see.
And I was confused if there should be another view. So I was trying to find another view. I was like, oh, well, I'm getting this person along. So I guess that's what we have to go off of. That's all we're using. So we didn't really know what resources were there for us either. So
Great. Well, that's going to do it for our very abbreviated debrief. Thank you all. Great job, Stanford. And next up is going to be Washington, St. Louis. Hopefully I can make sure the sound works right this time.
And Jane and I will try to do a better job on timing and sound. So well done, you guys.
All right, Washington, St. Louis, here we go.
All right, Joe, can you get us hooked up onto the monitors, get IV? Did this patient come by themselves or EMS?
I don't know.
Hey, okay. Val, do you want to start doing a physical
Yes.
exam? Jenna, do you want to maybe pick up the iPad? Sure. Sir, what's your name?
I'm Jason. Jason
Hey,
Smith.
what's going on? What brought you to the ER?
I was out jogging today, like usual. And about 10 minutes into my run, my chest started to hurt and I felt out of breath.
Is it still hurting right now?
Yes.
Yes.
Sharp.
Okay.
Sorry.
I'm assuming pulse symmetric? Yeah. So he's a little tachycardic. Are you feeling short of breath still?
Yes.
Any reason
I feel lightheaded.
Cough?
No.
Lightheaded? No. Have you ever
Last
anything
week I
like
had a
this?
cough, but I've been feeling back to normal since yesterday.
Okay. Any ever had symptoms like this before?
No.
No? Okay.
I don't have any medical
trauma?
problems.
Any recent trauma or
No.
anything happened? No? Okay. Is it okay if we get you undressed? There we go.
Okay.
A towel? Okay. Any nausea?
No.
No? Or does the pain radiate anywhere to your back, on your arms, up your
It's
jaw?
not shooting up to my jaw or anything, just where my heart is.
Okay, can we get a temperature somehow?
I will get a temperature.
All right, and can we get
Here, Joe. Temperature.
Are you putting in some orders for it, Jenna?
What orders
What
would
you
you
got
like?
so far?
I have not ordered anything.
An EKG, 38.1. All right, let's do some Tylenol. Okay.
EKG
How old are you,
is
sir?
ordered.
I'm 45.
45. Let's get him some. Do you have any allergies to medications?
No.
No. You guys want to give him aspirin as well? So let's do with meds. I would love a CDC, a CMP. There you go. You're calling in. Read advertising. Protein P. Oh. Go ahead.
Is that aspirin? Is it going in? Aspirin 324 PO.
Electric.
Do we need to do ultrasound for you?
Have you been on any recent long flights, travel?
No.
Any recent surgeries? Yeah, okay.
No.
His lungs are clear, there's no long flights.
All right, hold on, so I can hear you.
Sure. Any medical problems in your family?
My parents are both alive, no heart problems. But I think my mom had a blood clot in her leg a couple of years ago.
Okay. Do you remember why she had the blood clot or what was going on at that time?
I don't know.
Sounds great. Yeah. Is there an EKG machine in here?
Okay. I dropped the iPad next to
Can you put him on? Hey Joe. Yeah. Can you put him on 2 liter nasal cannula?
Okay.
Yeah. Oh. And then now. What are you doing?
Looking for PKG pad. I have the chest X-ray for everybody who wants to look at it.
All right. On the chest X-ray, I see normal heart size, clear lungs, no widened mediastinum, no pneumonia. Probably stomach, free air, really under the belt. All right, let's go ahead and put him on a non-rebreather.
I can't breathe. I'm really scared, doctor. Am I
Okay,
okay?
it's going great. EKG somewhere. Do you have a big dilated heart part?
Recycle his blood pressure.
Sure, that'd be great.
Okay, here's the EKG. So far, here.
Oh, blood pressure 74 over 40.
Oh, I'm starting to feel really lightheaded.
Is that? I think he's got a big PE, guys. Yeah, he's got a big dilated
And he's
artery.
got kind of
So let's start him on the TPE though.
Okay.
Let's do some lytics now with a massive E of dynamic instability.
I can't breathe.
Okay.
Can you hook up the oxygen to the wall? Joe?
Yeah. I do not have the.
And let's go ahead and start a second liter of those fluids.
I do not have norepinephrine, nor do I have heparin. I do not have TPE. Oh, here's norepinephrine.
Yeah.
Okay.
All right, norepinephrine. We'll start it.
Oh, I'm starting to feel really lightheaded.
Take a deep breath.
I can't breathe.
So titrate, so we'll
Air.
Do a map
so titrating this one at oxygen saturation. Okay. So we have
a pulse.
We have our.
I don't have a pulse, so can we start CPR?
Okay.
There isn't. Well, I guess start heparin.
Yeah. There's an order for a heparin bolus and a heparin infusion.
Let's do that.
Oh, great.
All right, is our norm.
Okay.
What do you guys think? Let's have a timeout. Everybody in the room. So this guy came in with chest pain, shortness of breath, rapidly comes in with X-ray hypotension, hypoxia. He was also febrile. That wouldn't necessarily hit you, yeah. We've given him fluids. Are we starting on a second liter of fluids? Keep giving fluids. We have no evidence of pulmonary edema on our chest X-ray. So CHF low, right? Myocarditis maybe, but his EKG looked largely okay.
Yeah.
Right.
Echo
was concerning for.
And he had no neurologic symptoms, so you don't think he has a head bleed, so the lower risk of.
All right. So let's do it.
Yes.
Let's do it. EPA bolus. Thanks, Joe. All right. We'll pause for a pulse check.
Stopping.
Okay, now you have to take your hand off and pick again.
No, we've got that.
Unfortunately.
Joe, can you cycle a blood pressure for us? Then I can get an A-line.
I can.
And Val, can you intubate him, please?
You do not have A lines. What medications do you have running right now in the
We have
code leader?
norepinephrine and IV fluids. We gave a TPA bolus. I guess we should name the TPA drip, guys.
Yep. Joe, we'll have to order it on the iPad.
All right.
I'm going to intubate him.
Nope.
If you order it, Joe, I will go to the machine
Great.
and get it.
All right. I'm on the ventilator. Is there a ventilator? You're just back.
Okay. That's
I think you have to bag him in there.
That's fine. I can do it. So I just have the
yeah. Let's just up a little bit. So head of the vent up a little bit.
Here's TPA. Here you go, Joe.
Awesome. And then cycle that one.
I can.
All right, guys.
Cycle BP. Okay.
Did we lose pulses again? Yep. All right. Okay. Restart.
Okay.
Okay, starting CPR.
The slow walk. Is that CPR? We're resuming CPR. Oh wait.
Okay,
Oh
starting
no, we have
CPR.
pulses. Oh, stop CPR.
Stopping CPR.
Yes. It's so hard.
Still have pulses.
I got pulses. I got pulses.
Blood pressure.
Great.
All right, recycle blood pressure. Do you want to start an epinephrine drip on this gentleman?
Does that mean you'd like to stop the norepinephrine?
I don't know. I think we should probably. I think we should.
Okay,
What again should we call IR or somebody? Thinking?
Yeah.
Or call the MICU?
Yep. And
And since he was febrile and tachycardic, we'll just go ahead and cover him with broad spectrum antibiotics.
Yeah.
While we're at it.
Get it.
Yeah, we can cross some blood cultures, that'd be great.
If these oxygen sensors.
Can you tell me what medications you have running?
Norepinephrine, epinephrine, and TPA. CSA says we can restart CPR. Go do the epinephrine. Okay. It's 10:22.
All right. IQ 6. You guys elevated.
Is there family anywhere?
Is there
we
any
can
chart
call?
history also? He has no past medical history. Yeah. Family history of, the hyperacute and the
S1, Q1, T3.
Yes. Yeah. Okay.
Yeah, we got, that's what I'm saying. We need to look at all of our labs and stuff, but we really need to talk to him.
His skin was okay. Yeah.
Hello, this is the hospital operator. How can I help you?
Oh, could you please call the
There is no way to talk to family.
I don't know.
No, it's just expressions.
Can you consult interventional radiologist for this?
No.
Is there a consult for IR in the order set? There is not.
There's not.
Can you
It's just
consult
us, guys.
for, I think it is two, cardiothoracic for ECMO? Clearly too unstable to transfer.
No.
All right, I think actually this is a good place to stop.
All right, that was great. Judges, we'll turn it over to you for your 5-minute debrief.
Hi guys from Washington, St. Louis. So obviously we heard from the Stanford team how difficult the technology was. What was the experience like for you guys? Obviously I saw a couple of glitches, but I'd love to hear just a little bit about what your thoughts were and your experience.
Yeah, I think working with the virtual reality, this was new for all of us, and this software was really new. It was really cool and innovative, but as the Stanford team talked about, there were difficulties, like if you were in the middle of administering a medicine and you accidentally dropped it, then you had to start all over. Like at one point I accidentally took the pacer pads off. Like that was something that we didn't expect and just required more communication than even your typical average sim, which at baseline requires a lot of communication.
But I think overall it was really fun. I mean, there was times where we felt the pulses were there, and then we had to stop CPR, and we kind of like lightheartedly felt that it was there, so then we stopped. Something that you would normally be able to feel in a real sim.
Just the leadership. Who was the leader of the sim?
Her name's Emily. She's actually a SICU in the SICU right now as a fellow, junior fellow. So she's here.
This is like Inception. It's like video in video. Yeah. Right. I love it. So I mean, obviously super challenging because you, obviously as the leader, it seems like you can't see all the things that your team members are seeing. I saw a lot of like people just giving suggestions or jumping in. Like what was that like? Instead of you giving a lot of orders to your team, it felt almost like it was the opposite way, like your team was really like just pitching in and helping you out.
Yeah, I mean, I think that we worked well together in the virtual like VR space. It definitely was harder to kind of get a feel of everything that was going on in the room, especially kind of with like the iPad. Oh, can you guys see me?
Yeah, keep going.
Okay, especially kind of with the iPad, not being able to see some of the results. So I needed Jenna or somebody else to kind of tell me what those results were, as well as kind of feedback from the ultrasound. I felt like I was able to get good information. So I appreciated that communication kind of from the team, but a little bit different feel than kind of just standing in the trauma bay and being able to kind of get that real life feedback and see most of everything that's going on in the room. And always with sim too, it's kind of getting information fast, right? Instead of like having a second to process, you know, an X-ray or labs or something else kind of in the sim world is always sped up.
Yeah,
One thing we also
So that
talked
was a little
about, one thing we talked about last night too, is that because of the platform, we as compared to a sim when you're all in person and actually working with a mannequin, it does require more cross communication, because I accidentally drop a medicine, but Joe's closer and I say, hey Joe, can you pick that up? And so I think just because of that nature, it led to more communication outside of just the team lead. But I think what we talked about last night immediately after was that we didn't really feel that it detracted. Like, we still knew that Emily was our leader, and we still took things back to her. Like, the final decision was coming from our team lead.
Yeah, obviously very, very difficult, sim medium, but I think you guys did your best in the situation. I'm going to turn it over to Dr. Griswold and Cobalt.
Thank you.
Always happens, you start talking and you're on mute. So anyway, thank you, Dr. Kim. Again, I think this format is really interesting. It's amazing to watch you guys, and kudos to both teams for, obviously getting the diagnosis, getting TPA, and trying to save this person. I really did also like that you guys were trying to contact family before potentially pronouncing him. I like that you
just like combined like ER medicine program.
Okay. Yeah, so sorry. Anyway, but I won't take up too much time. I heard so much more background noise with your experience in that virtual world than I did in the Stanford one. I don't know what was really different about the two situations, but it was so much harder for me to hear the communication amongst you guys. And so again, it's just a very different and new world. So I'll turn it over to Dr. Cobalt, but I really think both teams, thank you for doing this. It's really an amazing platform to be able to share this learning environment.
Thank you, Dr. Griswold. You did notice the audio difference, and that's due to just different recording strategies, where we had a failure of one of our audio feeds during our recording for part of it, and so we had to mix in the screen cap from one of the laptops to fill that gap. So that's why, it was a challenging audio environment that spent a lot of time messing with last night. But I do, as far as the case goes, like I did notice, like, I like that, you did a nice recap, like, okay guys, here we are, this is what's going on. Can we take a second and pause and talk about what's going on? There was a challenge with the communication where, so the critical actions, both teams got basically all the critical actions, but you had to do a certain order to end up finishing the code. They both gave TPA, which is kind of the big part of the case, but the way the case is written, you actually have to give heparin as well. And so at least for the WashU team, they mentioned heparin, and they say, okay, let's do some heparin, but there's no, because of just having to both order it in an iPad and then get it out of the Pixis and do it, it doesn't actually happen. And so that's part of the challenge. You heard kind of Dr. Rivera saying, okay, what medicines do you have going right now? Just a prompt to be like, okay, are we actually giving the heparin, I think. And so that is a bit of a challenge just from a sim perspective too. Like, sometimes you don't hear what the learners are asking for, or so you try to confirm what they have going. I do like that you try to contact family as well too. So I mean, I think overall, technical challenges aside, I think both teams did a good job adapting to the new medium with kind of minimal orientation, and doing a good job working as a team together and working on that communication, like feeding information back and forth to each other in a challenging role, and then kind of having to decide what to do when it's not going well. Both teams did ask for like ECMO and IR and some of these things, but we included a clip from, if you picked up and called the operator, they were totally unhelpful. They're like, no. They're like, can we talk to this? And they're like, no. And you're like, we call IR? They're like, no. So you don't have a lot of backup at SIMX Virtual Hospital that you could normally bring to bear to help you fix this case. But that was kind of on purpose, trying to force you down a specific pathway and kind of recap and press forward. So I think both teams did a nice job in both their adaptation to the case and getting over some of the technical barriers that we experienced during running the case live each time.
So that's amazing. And again, WashU team, thank you for getting all your team members, even virtually. So, well, I appreciate, we're trying to give every team like the same experience, like judging wise too, but we are gonna have to do a better job going forward with managing our time and our debriefing. Okay, so it's the speed debriefing going forward.
All right. So thanks, everybody. So we are going to open the polling for voting. You'll see a QR code in front of you. If you follow that, you'll get a link. Team A is going to be the first team that went. That's going to be Stanford. And Team B is going to be WashU, the second team that went. Team A is Stanford. Team B is WashU. Polling is opened. And Dr. Sampson will announce our winner of the first round once polling is ready to be closed.
Yeah, we'll give it a few more seconds here.
It looks like the Stanford team has brought out the wine now. Is that correct? Their beverages now.
10 more seconds.
And I mean, I would, yeah.
Oh, sorry.
No, I was just going to say the chat is a way to give some feedback. You know, we don't have applause, but everybody can put some virtual applause in the chat for this courageous team.
And our winner for the first round is Team B, WashU. So congratulations to both teams.
All right. Thanks, WashU, and thanks, Stanford. Really appreciate your participation. We're going to go on to the second case now, and we're going to invite Dr. Barbieri to turn on his video and tell us a little bit about the case. The two competing teams are Cleveland Clinic, Akron, and University of Florida, Jacksonville. So those two teams can turn on their video as well. And Pedro, I'll turn it over to you, and you can tell us a little bit about what we're going to see.
So the cases that you guys are about to see were the test trainers case. So what we did was we actually shipped both teams a box containing 4 test trainers that they had to complete. It was sort of like a relay race. They had to complete all four test trainers in a row. They could only move to the next one once they finished the previous one. They couldn't go back, and also all the members of the team, they each had to lead one of the cases. All the supplies, all they needed was actually inside the box. They opened the box only when they were instructed by us. The first test training, we had to do a little bit of preparation before we started because it involved a little bit of water. You guys are gonna see why on the videos. And that's pretty much it. They had 8 minutes to complete all the 4 test trainers. If they didn't finish by the end of the 8th minute, we would stop the simulation, and they will be judged based on what they did up to the 8 minutes. I think that was it.
That's great. So UF Jax is going to be up first. We'll load this up, and away we go.
1, 2, 3, go.
Woman in the 38th week of pregnancy went into cardiac arrest. It's been 4 minutes of resuscitation. No ROS. Perform a cesarean section ASAP. Okay, so this is the abdomen. Okay. This is the umbilicus. All right, so we have a scalpel at bedside.
Where's the?
Can somebody be doing compressions?
Yeah, guys, unwrap the box. Unwrap. You can take. Yeah.
Okay. So Rick, I want you on doing compressions. Okay, I'm probing at the level of the umbilicus. I want Chelsea to put her on the monitor. She's on the monitor. We have I'd like 2 large bore IVs, and let's pull a rainbow. Here.
stroller prepping your.
Well, Chelsea, could you get OB on the phone and get them, try to get them down to the ER? Let's get
I'll be on the phone
let's
all the
call peds and let's get a baby warmer.
Baby warmer set up.
Okay, so I'm going to make a vertical incision. Vertical incision. Got fetal head. Do we have somebody ready with the baby warmer?
Yep.
All right, I need 2 clamps. Okay, can we get 2 clamps?
Yep.
Can we get a bulb suction?
What's it say on the back of the baby? The same thing?
It does. So let's clamp that. It says baby delivered successfully. APGAR's 10 of 10. Mom died. No need to close the mom. Move on to the next trainer after you finish delivering the baby. And cut the cord. We got bulb suction. Okay.
It's complete.
Task complete.
Alright, task 2. Oh no, this is not good at all. 3 weeks of local pain, edema, redness, and increased temperature. Treat the abscess with a loop drain.
Already.
Penrose drain. Okay. Floor prep. So this is our
Lidocaine.
abscess. Gonna clean around. Gonna use our lidocaine. Do we have anything to draw
We
it
have
up?
a blunt tip right here.
Okay. Syringe. Thank you. Any other? Yep. Here's another one. 25 gauge. Yep.
What's your time?
4 minutes left and 5 seconds.
Needle down.
Safety, you're gonna take your sharps off the floor.
Your scalpel is here.
Loop drainage. Do we have anything to make a loop?
It's right here. Yeah, they have a Penrose.
All right, so I'm going to numb up the surrounding area.
We're good. Too much.
All right, then I'm gonna numb up centrally as well. All right. Scalpel. Gonna make an incision.
I think the loop drain is just like 2 spots and you go through it, right?
Okay.
Yeah, so make another one.
Doesn't matter where.
Yeah, and then you gotta put it underneath.
And you're gonna loop through. So
See,
pickups,
like-
where
I would say
the pickups?
Pickups.
Load it. Bring it through.
And then tie it and put it and drain it.
All right, so putting it through.
3 minutes left.
And then you just tie it.
Just tie it off and just try to drain some pus.
Okay.
One more. Good.
And then we're draining all the pus.
Cool. Task complete.
That's complete.
Obese patient with a filled airway can't intubate until option. Let's try to do that. Maybe a scalpel or fluid. Do we have an ET tube that we can go ahead and get out?
Floor prep.
Easy. We have a 7.5.
Watch out, guys. We're gonna turn the patient this way.
We got
Head.
5 fingers from the sternal notch, or 4 fingers from the sternal notch.
Right here.
Making vertical incision.
I got your boogie, I got your ET tube.
In the airway, can I get a bougie?
tell me when. I'll preload. I'll load.
Go ahead and preload.
All right. And meanwhile, Rick, can you get them on the monitor as well?
Yep.
Okay.
Balloon. Wait. One down. We're just having a little bit of issue, like the actual trainer itself. All right, balloon up. Balloon up.
Bougie up.
Bougie out. Bag.
Do we have
Are we task complete?
Task
Brian?
complete.
Open up.
1 minute, 20 seconds.
During the auricular hematoma, don't forget proper dressing.
Auricular hematoma. Okay.
I need a 10 blade, I need lidocaine.
10 blade right there. Got your
10 blade,
lidocaine. What
lidocaine.
tip?
Here's some syringe.
Drawing
Here's
it up.
it's already drawn up.
Lidocaine drawn. Chloroprep doing a field block. All
Chloroprep.
4 sides.
Do we have a suture?
So
Yep.
taking the
Bolster
10 blade.
dressing.
Longitudinal. Huh?
1 minute.
1 minute.
We have
Longitudinal
some
incision.
Coban.
Drawing 2 incision here.
Where's our Coban?
Got it out.
You got a suture preloaded.
So drains, we're gonna put some gauze around it, and I'm going to suture the gauze in. We have Covan. Give me Covan instead. I don't need a suture. Give me Covan. We'll wrap it with a compression dressing.
Right there.
Here, bolster
Wrap.
on both sides. We got bolsters on. We have 2 bolsters on both sides.
Coban. Wrapping around the head, compressing.
Pressure dressing. Can we cut it?
Just want to take that
Good.
earring off as well.
Oh, I don't see it.
Earring is off.
I don't know how to get the earring off.
Looks like task complete.
Yeah. Task complete.
Earring off. Earring off.
We're done.
Good job.
Wait. Yes.
All right. That was great. We'll have our judges come back on and can start your 5-minute debrief.
Thank you so much, Jacksonville team. That looked like so much fun and so terrifying all at the same time. So why don't you guys just tell us a little bit about this experience? We're going to try to, again, make the times equal for each team. Again, also with our third judge who comes in, the case creators, make sure that they limit their remarks to like just 1 or 2 minutes. So we keep on time today. This has been so much fun so far. So Drs. Goldberg and Sampson, you rock, and this whole team. But why don't you guys tell us about that experience?
It was a lot of fun. I think we all were pretty comfortable with the procedures themselves, but we're a little confused on like what we actually needed to verbalize or talk about, especially like on the first task and early on.
The first task early on, like get actually didn't realize that you had to open the bag for a little bit.
Yeah.
And then like we were calling for OB, for peds to come down to bedside, for large IVs, for monitors, for chest compressions, and it was a little unclear at first if we were just doing the procedure or we're resuscitating and doing the procedure, which is why it like became a drawn out thing.
I think as we got further along, we all kind of helped each other out a little bit more and had some pretty good teamwork as far as like loading the bougie and getting the cuff ready to go for the ET tube on the crate and all of that. And we also kind of picked up our time once we realized this was probably more for a time type of situation.
So if there's anything that you would have done differently if you got to do that whole thing over as a do-over, what would you do differently?
Open the bags immediately.
Yeah.
Back immediately, be a little quicker and less verbal.
All right. Thank you so much for doing that. And I'll turn it over to Dr. Kim and Dr. Barbieri. Thank you for making such a very cool task for them to do.
Yeah, just quick comment. I thought you guys did a great job. Clearly you guys are confused and so gentle opening the envelope and like looking at the bag, and then by the end you guys were like, it was like Christmas Eve. So it was like so funny. Yeah, I thought you guys did a great job communicating. Obviously you guys know each other very well and are very comfortable. Loved when you guys were doing the ET tube loading and communicating so well. So great job. It was really fun to watch. Dr. Barbieri.
Yeah, I also think you guys did I don't have much to add. I think you did a very good job. I understand the difficulty of knowing what exactly you were supposed to do, but being more verbal actually made you guys talk to each other and help each other out. So that was good to see that kind of communication. Regarding the test trainers, I mean, the skills and how to do the procedure. I think you guys did everything very well. You did the incision well. The baby was out pretty fast. You also drained the abscess correctly. Didn't tie the loop too tight. When you moved on to the crike, you remember that the landmarks and the four-finger rule to try to identify the main brain. Moved pretty fast with the procedure, and you guys finished with 8 seconds left. And you did that, there are a couple different ways to do the dressing for the auricular hematoma. You chose one that's very time effective, so that was in your favor. So yeah, I think you guys did a good job. Yeah.
Yeah, I think it's amazing too, like the chats, the feedback in the chats also coming through. I imagine if with the resources that are on this panel and this Zoom, there's probably a whole textbook that could come together with all the feedback in the Zoom. So thank you very much. Well done.
All right. Next up is going to be Akron. And away we go.
I'm gonna count you 3, and then you guys can start. 1, 2, 3, go.
Woman in the 30th week of pregnancy went into cardiac arrest. It's been 4 minutes of resuscitation with no ROSC. Perform a perimortem cesarean section as soon as possible. Okay. Wonderful. You taking the lead on this one, Tony? Sure. All right, sounds good. What do you need from us?
He has a scalpel.
Have a scalpel. Head, mom's head.
Here we go. This is for umbilical cord.
Sounds good. I can clamp that when you're ready.
This is for cut.
All right. Johnny, do you want to cut?
Wonderful. So incision from
the
xiphoid to the pubic symphysis vertically.
Yep.
Wonderful.
Okay.
Good work.
We're in.
All right. Do you want anything to kind of spread it open?
So he's dissecting down to the uterus.
Down.
I'm opening her.
We're inside. Filling for the head.
Are you in the uterus already?
Yes.
Okay.
All right. I got it. Do you need me to extend your incision?
No, I got it. Okay.
Wonderful.
Good.
So I will call OB and notify them that we have a code pink.
Okay.
Alrighty.
Baby's here.
All right. Cut him out.
Okay. We have another label. Baby delivered successfully.
Yep.
Apgar 10 out of 10. Mom unfortunately died. No need to close the mom. Move to the next trainer when you're finished.
All right, opening task 2.
Get her over to mom.
Can someone open this package? Oh no, this is not good at all. 3 weeks of local pain, edema, redness, and increased temperature. Treat the abscess with the loop drainage technique.
Oh, I don't know the loop drainage. Johnny, do you know this?
I don't know.
Okay.
Drainage? Oh yes, I know.
You just did it. You have to walk me through it.
Okay.
Go ahead.
So you have to make 2 incisions, and you're gonna put a loop between the 2 openings.
I should lie to.
Here, I get it.
Yeah, it just has to be a thing.
Those go in between the 2 incisions.
Okay.
Yep.
And you tie it. Wonderful. I am consenting the patient for the abscess drainage.
Patient consents well.
Wonderful. All right, lidocaine's here.
All right, I need not a
really quickly?
dull needle.
Floor prep.
Okay. There is a sharp on the field. Watch out. Do you have a needle? All right.
The patient has been consented.
That one we're done in case we need it for the
Abscess has been chloroprepped. Lidocaine currently
Tony,
being
what time
injected.
do we have?
We have 5 minutes left.
Okay.
Another sharp on the field.
Okay.
I'll just stick that.
Watch yourself.
Make sure you express some pus. Deloculate the abscess.
Good work, Alex.
Lots
What can
of
we do to
pus.
help?
Easiest way to do this: stick this through one, pull out the other, and then grab your.
Jesus, I need something.
Go.
Go. Oh, wait, task 4 only. Task 4 only.
Task 4 only.
Psych. You're on.
Okay.
Oh, there's some here.
There we go.
Cool. Toss it
Nice and juicy.
You need to put that
Yep, I sure do. Oh.
There you go. Just
put your hemostats through and then grab it. It's the easiest way. Or that way.
Nice, nice, nice.
Where are we on time?
4 minutes, 20 seconds left.
Right.
And do I just tie this?
Yep, just tie it.
Cool. Take a 20-second breather. Don't want to make it too easy. And we'll restart.
All right.
Just to keep it open.
Feel good with that? Feel like that one's completed, looks good.
Drainage
Yep.
successful.
I'm looking.
That's 3. Obese patient with a failed airway, can't intubate, can't oxygenate, perform a crack ASAP.
Wonderful. I'll do this one.
We have a scalpel.
So I need a scalpel.
Got it for you. Just get what it. Tell them what else.
I do we have a bougie? This will work.
Yep, we have
Yep,
a
there's a
bougie.
bougie.
Donde está?
Head,
There
feet,
you go.
good. So I'm gonna
Did you get it?
swipe
Oh,
upwards. I'm gonna identify the laryngeal prominence. Right here, pull the skin back.
There.
So first I'm gonna make a big vertical incision downward. Ooh. A little bit of edema, excuse me. Incision downward. Identify the cricothyroid membrane.
All right, balloon works.
Good. Finger is in. And then I just need my bougie. Bougie is in. Then do I have a 6/0 tube of sorts?
There you go.
Syringe?
I already have it on there.
You got it?
Yep.
Perfect.
All right, let me know when you're ready to
In.
inflate.
Go ahead and
Balloons
inflate.
inflated.
All right, you're 16.
We're bagging.
And we are now bagging.
All right.
Good.
Call X-ray.
X-ray verified
All
placement.
right, perfect. Let's move on to task 4. Does someone want to read this while we're opening?
Do you have to wait to be open until we're done? Jiu-Jitsu National Champion and is in the back of the ED. Drain the auricular hematoma and don't forget proper dressing.
All right, so someone will have to walk me through
Yep,
it.
that's fine.
You got to remove this carefully.
So once you drain the hematoma, I'll show you how you're gonna dress it.
Oh, nice. I like the earring.
So what we're gonna go ahead and work on.
I would
that.
take the earring out.
All right.
Okay.
Sweet.
There we
Alright,
go.
So we've got some lidocaine. Injecting some lidocaine.
So inject here and do a preauricular. You could block it.
Okay.
So you're gonna go this way and that way.
Did that look good?
Yep.
All right.
And
So
then
the
down
block's
here.
in.
And then Johnny, do you want this?
Yeah,
It's kind of
I have them
Okay.
right here.
Oh,
Actually.
you got in there?
All right, so
You have a drainage. You're gonna put these on either side, and we're gonna suture straight through. Make a
Oh,
nice pressure
okay.
dressing.
You have to. Are we gonna?
Did we get that out first?
You gonna drain this first?
Oh, okay.
Here's
I'll
your.
hold this for you.
And
I already did the lidocaine.
You already did the
for that.
lidocaine,
Yep.
perfect.
Here's the lido block. We have a scalpel here. Want to make sure to go with the curvature of the ear, so you
So just kind of
keep
down
it
like this there, right?
Look at you, kids are natural.
All right. So there's
Oh.
that.
Oh.
Just kind
Do you have anything else?
Yep, there you go.
express that.
Yeah.
Okay. Sharp on the field. Let's do the pressure dressing like you
There
guys
you go.
talked about.
So this thing, and then kind of try to approximate the ear as best you can with those.
1 minute, guys. 1
Something like
minute.
that.
1 minute left.
And then you're just gonna sew straight through.
Straight
Through the ear.
Through the ear, through both dressings.
Yep. You want to keep that pressure. Watch your finger on the other side.
I can hold here, I believe. Boom.
There you go.
Look at you.
She's a natural.
Kids are natural. Not a boy.
There you go. There you go.
Okay. Well, no.
Or do you want to just
That's
do it
fine.
through
Just do that. We'll just do two simple interrupters. It should work
That's fine.
for the purposes. Can you grab the needle? Or is there a scissor over there? Or
Yep.
something like that? Oh, I like where your head's at.
This?
Just doing a mattress?
Yeah.
Perfect. So tie that.
Watch your
and then
fingers.
We're good.
Okay.
You can tie that really quickly.
There it is.
Where are we on time?
It's about
15
Here,
seconds.
take that. There we go.
There you go.
And then we could do this around the head.
Oh, time is up, guys. Sorry, you can stop.
All right, great job. We'll turn it over to the judges.
All right, again, Akron General, awesome. There were again a few of the things put in the chat. This is a wonderful experience. You know, certainly we would have never done anything like this in person. So I'm amazed by the creativity of these teams. But when we talk about doing we call it resuscitative hysterotomy now because we really do hope to save mom and baby. And, again, my thing is just like technical, just try not to do scalpel. But for the most part, I think you guys as a team worked amazingly well. When someone had to do the task and they weren't the most expert, I loved the way you guys worked together as a team, even did the auricular incision around the hematoma. And as Dr. Riviere said, there's so many different ways that you can do the dressing for the auricular hematoma. I think that you blew through all of the tasks very well. Dr. Falk had put in the chat, if you do end up using the ET tube for a crike, make sure you are cutting it down. So you have to like cut it and of course put the tube back on the end. So sometimes it's obviously with this time constraint, it's fun and it's an amazing task. But again, well done, team, and it's just I'm amazed and impressed with everyone's skills. So thank you for doing this.
Akron, this was so amazing. I'm so glad my video was off because every time during that emergency C-section, I'm like making like the worst face because it's so real. I can only imagine what that experience was like. So kudos to Dr. Barbieri for making these amazing task trainers. So I really want to focus on that last task where actually one of the team members says very clearly, like, I don't know, you guys are going to have to walk me through. So tell me what you guys were thinking, like as a team, like how you guys managed that. That was amazing.
I mean, I think we went forward. So we have a senior, two third years, a second year, and a first year. So obviously there's kind of a different knowledge base there. So we just went through, hey, if you know something, like just take that one first. So our seniors ended up doing the first one and the third one, and then our intern did the auricular hematoma. So we were just like, be very blatantly honest. If you don't know something, and we'll walk you through it. So while someone else was doing one thing, someone else was walking him through the block, someone else was getting the bandage set up. So I think we just kind of like self-selected what we were gonna help him out with and kind of go through that, just knowing that he needed help with it. But I think we made it very clear, like if you do not know, just say it out loud first or else we're gonna waste a lot of time.
Absolutely, I think he did great too, especially being the first one he's done. So I think he definitely did great, especially under the pressure of the time constraints.
Yeah, I think it was really great. And then just the courtesy where you guys were like, there's sharps on the field and all of that stuff was really impressive. Given like you guys are suturing, I was like, oh my God, they're going to suture their fingers together. This is the worst thing ever. But you guys were very considerate, I think, throughout. So kudos to you guys. It was amazing to watch.
Yeah, guys, I agree with everybody. I think you guys did an amazing job. I'm glad you guys had fun. When we were designing those cases, we wanted to make something that would be messy. So if you look at all the test trainers, they're kind of messy. They all have blood. They all have something. And I really like how you guys communicated to each other. It was actually more than one case that somebody said, I need help with this, and everybody helped out. And the task was done. You guys completed it, and you did a very good job. I liked how you really drained the abscess very well. You really got all the pus out of the abscess. That was very nice. And one thing that a lot of people made good comments on the chat, and one thing that I would add for the first test training is that because usually we're doing this midline incision because that we're not OBs, right? We're not used to doing the traditional one. Sometimes what might happen is you might actually fall into the placenta because the placenta might be in that position because you're not doing it to a incision lower, right? So that might become also a challenge. But anyway, you guys did amazing and good job. Good job.
And so congratulations to both teams. For those of you that still have the voting link up, you just need to refresh. For anyone else, the link to vote is on your screen. And Team A is going to be Jacksonville, and Team B is going to be Akron. So University of Florida, Jacksonville is Team A. Cleveland Clinic Akron is Team B, and voting is open. I'll turn it over to Dr. Sampson.
Yep, just give it a couple seconds here. I'm still waiting for more to come in. A few more seconds. We've got them. All right. And our winner is Team A, Jacksonville.
All right, congratulations, Jacksonville. So up next, we're going to ask Dr. Falk. I believe Dr. Falk's in the house. If Dr. Falk wants to turn on his video and bring it in. We have Jacoby Montefiore and UT Southwestern competing in round 3.
Please note the shirt.
There you go. Nice.
I had to dig it out of the closet, but I found the last Simwars shirt.
So Mike, want to tell us a little bit about the case that we're going to watch?
Sure. So what we wanted to do here, it's in some ways similar to the last one. So it's there's a task trainer in the middle of it. It's a limited resource case as well too. So the layup that the team's got is you are parents and you are at a parent-teacher day in school, and suddenly a kid starts choking, and you basically have to take care of this kid in a nurse's office with whatever resources are available to you. So to do that, we sent them mannequins, and I risked about $4,000 in UPS. So thankfully they've come home, and I thank you guys. So when they open up the box, you'll see there's a pediatric mannequin in it, and there's the utensils, all the necessary equipment is there. And then there's a second box, because what happens is, and this is actually based on a true case, the kid has an almond stuck in the right main, starts coughing, dislodges it, and it gets stuck in the throat. And now you go from a lower airway obstruction with anaphylaxis to an upper airway obstruction with anaphylaxis that needs a needle crike, just to make things fun.
Always. All right. And if UT Southwestern's on, if you guys want to turn on your videos as well, that'd be great. And Jacoby is going to be first up. And here we go.
Okay, so you guys are at, you're visiting with your kid at school, and you're at a school gathering, and you get called to the nurse's office. You're just down the hall and you hear help, help. So you see an 18-month-old male who's coughing and in respiratory distress, has vomit all over their shirt. They look uncomfortable and fussy.
We're gonna start the stopwatch. Yep.
Yep. And mom's sort of screaming in the background saying, "What's going on? Help!
Help!
Help!"
18-month-old? 18-month-old. Okay, we're starting? Yes. All right. Hi, Mom. I'm Dr. Ahmed, okay? I'm here with my friends Molly, Phil, and Mike. We're all doctors, okay? What's going on?
I don't know. I mean, we were just here and he started coughing and now he's vomiting and like he can't breathe. I don't know what's happening.
Okay. Phil, can you put the patient on a monitor? Do we have a monitor around and a nurse?
Hi, I'm your school nurse. I have a manual pressure cuff here and one of those portable pulse oxes.
Oh, great. Can you pass this over? And nurse, what's your name?
My name is Nurse Ratchet.
Nice to meet you, Nurse Ratchet. Okay, let's put them on the monitor. We'll put the clips ready. Okay, great. And nurse, can we get an initial set of vitals from your pulse ox and your blood pressure?
Yeah. The pulse ox is reading at about 90 to 92%.
Mm-hmm.
Your heart rate is, it says it's up in the 160s, and he's really breathing fast from what I can see.
Okay.
Have you inflated your manual cuff?
Yeah, the cuff is inflated.
Okay, the manual pressure is 70 over 50.
70 over 50. Okay. What do I see? So, Mike, what do you see, hear, smell? Yeah, what am I seeing?
Yeah, you're seeing a kid who looks really uncomfortable, who's crying, has vomit all over his shirt.
Okay. So we hear some striders things. Do I hear anything different other than strider?
You hear wheezing throughout. Stridor, you're seeing tachypnea and retractions throughout and decreased aeration overall.
Okay. Mom, does he have any medical problems? And nurse, do we have any oxygen in the school that we can provide him?
I have a portable tank here and a face mask, and I have some albuterol. I can give you a nebulizer of albuterol if you want.
Yes, some albuterol would be great, and some oxygen. And Mom, does he have any allergies?
No, but somebody gave him a candy bar, and after that, he just started vomiting. I don't know what's happening.
Okay. I'm concerned about anaphylaxis, guys. So far we got a kid who's hypotensive, tachy with stridor and wheezing. After some sort of food exposure, so I'm concerned about anaphylaxis. What do you guys want to do?
He definitely has food allergies, I can tell you that.
He definitely does. Okay, great. Nurse, do we have an EpiPen around?
Yes, you do. I happen to have an extra one for some reason hanging around.
Okay, great. Can we get that EpiPen, please?
You have it.
Okay, thank you. Molly, what's the dose that we're gonna give?
For EpiPen, it's 0.1 mg per kg, right?
It's something like that for code. Okay, so you guys look that up. In the meanwhile, I'm gonna try to talk to the parents. Actually, Phil, can you talk to the parents and try to get some more history while we're figuring this out?
Can you tell me a little bit more? Does he have any other medical problems?
No.
And
Okay, so it's going to be sub-Q is going to be 0.01
has he ever been
milligrams
into
per kilogram.
ever had to have an EpiPen before? Use an EpiPen?
No. I mean, look at the wraps all over his body. What is that?
Mom, how much does he weigh?
I don't know. I don't remember. I think he's probably like, I don't know. 30 pounds.
So we'll say he weighs.
Look in the mouth.
Yeah.
Is there swelling around the mouth?
So let's give the epi, guys, because the kid's in distress.
So the dose is 0.01 milligrams per kilogram.
So he looks like a 20-kilo kid. Mom, would you say that?
If he's 18 months, I'd guess closer to 10 kilos.
10 kilos? Okay, 10 kilos. So let's give
Let's give 10 milligrams of sub-Q epi.
Okay, so it would be iron.
Iron, yes.
Yes. Okay. So Mike, give the epi.
So we only have one epi, so I'm gonna give it to him.
Give it to him.
Yeah. Okay.
Yes.
In the thigh, right?
Yes.
Okay.
So we gave the epi.
Great.
Is this bandage covering anything?
He's still stridulous, and I'll give you his latest set of vital signs. His BP is 70/40. His respiratory rate is 30 with cyanosis around the mouth and getting worse.
Okay. So
Not that responsive, and his cap refill is over 3 seconds.
his cap refill is over 3 seconds. So hold on 1 second.
And I have this other like bag of stuff in my car. If you want, I don't know. I have some extra supplies.
Oh, if you have extra stuff, we'd love to have it. Okay.
Awesome. You can go ahead and open box 2.
Okay, guys, let's take a second and pause. So we gave epi. We need to give Benadryl. We need to give fluids. We need to give Pepsid if we can, and see what's in this box. Okay. So he's mainly responsive. Nurse, can we start fluids on the patient if we have an IV?
We don't have any IV.
We don't.
So let's see what we've got.
It's exactly what you have there.
Oh, we have a. I guess we have to cric him.
The cric tray. Do we have any?
If one dose of the epi, I don't know. I think there's a way to do a second.
Yeah.
Yeah. So do we have a second dose of epi?
Is there anything? Is there?
Just EpiPen we have. Is there any epi left after the
fluids?
first
Yeah,
dose?
there's always
Let's give the
more.
second dose of epi.
So I'm gonna have to break it open.
Okay.
Okay.
So break it open. Let's give the second dose.
I'm breaking it open with all the tools.
To look to see if we can just.
Hey guys,
Okay.
it's a nurse here. He's like not moving, and
Okay.
So
So Phil, prepare for airway. Get this open. We've got the kit here.
I'm giving another dose of epi.
And Molly, you bag. Molly, you get a bag. Mike, you give the dose of epi.
Do we have a little rigiscope to look to see if we can see what his airway looks like?
So what we do have though is a syringe fill, so we can do a needle prick.
Okay. I'm gonna do a needle crank. I'm getting a 14 gauge. Yeah, well, this is 18 gauge, but 14.
Okay, so Phil, palpate for the cricoid.
Popping for the cricoid.
Okay. Puncture through.
Yeah.
Okay.
Puncturing through.
Puncturing through. Mom. So what's going on is that it looks like he had an allergic reaction to something, and because of the allergic reaction, screw that in.
Yep.
Okay. Because of the allergic reaction, he's having difficulty breathing. Because of all the difficulty breathing.
Check for lung signs bilaterally.
Thank you.
Okay. We have to put something in his neck to help him breathe. Okay, so we're giving him oxygen through that. Nurse, do we have a wall O2 that we can hook this up to?
you have what you have in the little container you have there.
Okay, so we're gonna hook it up to the container.
Can we get a repeat set of vital signs, please?
So.
Okay.
What am I hearing on lung sounds?
It's
You have some, you are hearing some
I'm gonna call 911 to get EMS en route so we can get
I
this.
already have, guys. It's Nurse Ratchet. I
Called 911, and I'm on the phone with them right now. So they're telling me that there's a trauma center, an adult trauma center 15 minutes away, and then there's a pediatric institution that's a minimum of 1 hour traffic time at this time of day. They want to know which destination so they can give them a report about what's coming.
Okay. Does the Pete Center have a PICU?
Yes.
Yes, but they are an hour away.
Okay. EMS, can we travel with you? Are you an ACLS or a BLS?
It's going to be my understanding is it's a basic unit, they're telling us.
Okay. So, guys, let's think about what we've done so far, okay? So we've got a kid with anaphylaxis. We've given epi twice with some resolution of the symptoms. We did have to needle crack him, though, however, and this is not sustainable, okay? We only have a limited amount of oxygen, okay? I would go to the closer adult one. Okay, we're going to adults.
Perfect. Thank you, guys.
All right, we'll turn it over to the judges for your debrief.
Kobe, that was a stressful case. How? Tell me what was going through your mind. You're just hanging out at parent-teacher day, and all of a sudden this kid shows up. It's like everyone's nightmare. Tell me what you guys were thinking.
Yeah, it's always rough when you have to deal with an anaphylaxis in a supply closet. So immediately when we saw that it was a Pete's case, we were worried. But it took us like a second to kind of settle into a rhythm, realize what the differential is with what we were dealing with. Thankfully, we had the right tools on hand, and we were able to kind of get through the case after the initial jitters.
Interesting twist that Dr. Falk put for you, that, at the end you have a disposition issue of going to an adult ER versus a pediatric ER. How did you come to that decision amongst yourself and the thought process?
The biggest thing for us was that the needle crack was only a temporizing measure. You can't ventilate through that for a super extended period of time. So even though we would have liked this kid to end up in a PICU, we realized that with this BLS unit and with being a needle crack, we can't ventilate for an hour to get to the PTD. So we had to send them to the adult side.
I thought that was a great decision process on your part. And in the chat, I dropped the YouTube video of how you can get the extra dose of epi out of your EpiPen, which I love as a wilderness person. And I just love your communication style. I think you guys did a great job of, assigning someone to look up the dose, because, as EM people, sometimes we don't know pediatric doses, Dr. Falk, we just don't. So it's great that you guys assign people to look up stuff. So good job, guys.
Thanks.
Yeah, I
Dr.
mean,
Griswold.
certainly, yes. Thank you, Dr. Kim. Taking care of a child in this amount of distress in a closet in a nurse's office, communicating with the nurse. Yeah. So remember, there is an EpiPen Junior. It's really, there's two flavors as far as I know. There's the adult and then there's a junior, and that's all you get. So you really don't have to look it up. You just inject the junior. Mm-hmm. So again, I think what Jane said, I love the teamwork, the communication. Again, you don't often get to figure out what you're supposed to do because the box arrives and then that's what you're supposed to do. But just from an assessment standpoint, I really think you guys work well together as a team. Again, with a baby like this, remember frequent reassessment. You don't know if it's a foreign body. You don't know if it's anaphylaxis. And again, with a mannequin in a closet, there's not a lot of feedback that we were able to give you. But again, tough challenges all the way around. As Jane said, you made a decision. No matter what, you do have the four of you too, which is convenient that you all have children in the same place and you all have the parent-teacher conference at the same place. But with that, I'll let Dr. Falk throw in any other components of this case that he wants to talk about. But thank you very much, Jacoby, for participating. Congratulations on your win last year. And we'll turn it over to Dr. Falk.
Sharon,
Oh,
you
they don't know who Nurse Ratchet is. That's, I do have to say
did know
that.
actually.
They have no idea.
Very clear that reference went over.
No, it got edited out. They did know.
No, it's a one flew over the cuckoo's nest reference. I get it.
I'd like to say,
Yes, it is.
in sim, you're supposed to suspend reality. So of course they all go to the same school. Come on. You know, no, you guys did a great job. I mean, I'm sure that for most adult providers, pediatric airway requires that you have like little fecal houses in your pants after dealing with them, which is what happens to most adults, which is why we wanted to give you a case that was going to challenge you and we could get into a box. So, you know, you hit all the big teaching points, which is awesome. I didn't know about the 2 doses in the EpiPen. It was one of my colleagues who knew that. And I thought it was one of those great life hacks. That's really a good thing to know, especially when you're in an environment where you don't have resources. And people who know me know I work in places like that. So, you know, and the other thing is pulling the trigger on the needle crike. You know, it's a scary thing to do, but if you're going to do it, you got to realize it only buys you a certain amount of time, which you did. And, you know, the natural impulse for everybody, including EMS, by the way, they do this to us all the time, is to bypass the local adult trauma center that can accommodate a kid and stabilize them and spend an extra 15 minutes en route coming to us, which is probably not the best option for a situation like that. So great job, guys, especially the closet reminds me of a picture somebody posted in a group. He works in Chad and they were doing a procedure in a closet in Chad in a hospital. So kudos.
The best part, it's the exact same closet that they were in for ACE.
It's our good luck closet. Good things happen.
All right, so thanks, Jacoby. Up next is going to be UT Southwestern.
Okay.
Ready? When you guys are ready.
Ready. Let's go.
All right. So I'm just going to give you a one-liner and then we'll start our stopwatches, okay? So you are at your child's school for parent day when suddenly someone calls out for help.
Go.
Start your stop.
Philip, you want to assess the patient, see what's going on? Sure. What's going on with the patient?
So Christina, you want to go?
Christina, mom?
Yeah, I don't know. I mean, we're here for a parent day and suddenly it just doesn't look like he's breathing right. Vomit all over him. I don't know what's going on.
Okay, I look at the patient. What do I see, hear, smell?
Oh, sorry.
No, it's okay. He is coughing. He is in respiratory distress. He has vomit on his shirt. He appears very uncomfortable.
Okay. Mom, did we see him swallow anything, or was he playing with any small toys?
You know, we're here. It's like one of those things where they hand out some candy bars. I think he might have eaten a candy bar right before I got here.
Okay, I'm listening to the lungs. What do I hear?
Yeah, you hear stridor and you hear wheezing. You have overall decreased aeration. He's tachypnic and you're seeing retractions.
Is this inspiratory or expiratory stridor?
You're hearing inspiratory stridor.
Okay. And all the equipment that we were given is
I'm your
available.
school nurse, by the way, Nurse Ratchet.
Hey, Nurse Ratchet, can we have a junior EpiPen?
Yes, there is an EpiPen there, and I have an oxygen mask, and I actually have some albuterol nebulizer solution if you want that.
Let's do vitals.
Yeah, can we get the blood pressure and the O2 setup?
Yeah. Your O2 set is about 92%, and your blood pressure is 72 over 52.
Okay. Can we get an IV started? Does Nurse Ratchet know how to start IV in a kid?
We don't have any IV
No
equipment.
IV equipment.
It's a school nurse's office.
We don't
Sorry.
have IO.
We don't have an IO either, no.
Okay,
So,
let's go
no.
and get IV.
Yeah. Okay, we're gonna give our EpiPen to the kiddo. Or Nurse Ratchet can do it either way on the anterior lateral thigh.
Let's do some oxygen as well.
Yep.
Okay. And repeat vital
You want
signs.
my albuterol?
We can have it on standby.
Okay, and I have Benadryl elixir if you want to give it to him.
Okay. Let's go back to airway. Is our airway intact? Yeah. I sweep a finger in the posterior airway. Do I feel anything? Any masses?
You do not.
Okay. And I don't visualize anything either?
You do not.
Grossly? Okay.
After we gave you Epi, how did the patient change?
He still has stridor. He's still working to breathe, significant distress.
Okay.
Let's go ahead and start that albuterol. Let's recheck the oxygen saturation. And is the airway intact?
Yeah, he's still having stridor. He's still awake, and I'm putting the albuterol on him now as we speak.
Okay. Alrighty, can we do the rest of the?
Yeah.
We can do the rest of the exam. When I look at him, is there any kind of rash, redness, or injuries on his skin?
Yeah, he has diffuse urticaria.
Okay.
And his perioral swelling.
Alrighty, and then he has bilateral chest rise. His abdomen is soft, non-tender, non-distended.
Correct.
Okay, and the GU exam is normal. The rest of the exam is unremarkable.
Yes.
Okay.
Can we go ahead and call 911? Is there anything on the floor that gives any clue for a foreign body ingestion?
Say that again, sorry.
Is there anything on the floor that gives a clue for foreign body ingestion, like Legos, toys, anything like that? Okay, and let's go ahead and call 911 for transport to the nearest children's hospital.
We have some.
The only thing I can think is he ate that candy bar. I mean, I think he might have had enough of it. I don't know.
Yeah, so let's call this anaphylaxis. Do we have any more EpiPens?
Here, I'm a paramedic. Did you give the second dose in that EpiPen? I think you can.
Okay, we'll give our second dose of
I'll be right back.
the pen right now.
And
Here,
just
I also-
Ratchet, guys, he's really making a lot of noise, and this is getting like, blue.
Do we want to start
Yeah.
working with the bag?
Hey, yeah, also, sorry, dudes. I'm another dad from the classroom. I have this like box of stuff that I keep in my car. There's just some like extra supplies on it.
Yeah, go grab it. That's fine. I appreciate your help. Come back. Let us know when you're back.
You can open box.
Yeah, you're good. Where's the box?
You can
Box
open the
two.
second box.
Can we get repeat vital signs on him?
Yeah, absolutely. So his stats are dropping. He's about in the 70s right now. His blood pressure is 65/35.
Okay, we're backing
He's
him
pretty
now.
unfunded.
What about heart rate?
Heart rate by palpation is about 120 right
Okay.
Alright, so we have a card.
We just need to go ahead and crank him. Go for it. Okay, so we're gonna go ahead and crank this kid.
Yeah, he's not responsive at this point.
Yeah, let's go ahead and crank him. If we do anything for IV access in here, you work on crank. I'll look through here.
Is he bagging okay, or is it a lot of resistance?
No, we're doing needle crank. He's too
You're
young
not
for
hearing any breath sounds and no chest
Alright,
rate.
cleanness.
Don't worry about it. Just go.
Alright, so we just cleaned the area.
Palpated the
Palpating.
Palpating through the cricoid membrane.
Palpating the membrane, needle to the membrane.
Needle through the membrane.
Hook up the bag to this.
Can you describe what you're doing?
So I hooked up the 3 ml syringe to the 18 gauge angio cath, and now we're hooking it up to the bag. There should be another.
Is there another adapter for this?
This is what it is, and we're taking the end of the ET tube off, which is stuck in. Now it's not. And this is our adapter to the bag. Okay.
Okay.
Great.
Okay, we're bagging.
How are our sats, pressure, all that
Your
doing?
color is improving.
Okay. What
Your
about our
stats are improving.
blood pressure?
Low 80s. Your blood pressure is 80s over 50.
50s, okay. Do we have, is a paramedic here have anything for IV access nearby, or? He's
No,
still in your
sorry,
bag.
guys, I don't have anything else. I was
Oh
just
man,
looking-
IO kit?
Sorry.
Okay.
Thanks for your help.
We've called 911. We haven't.
Oh, so we, well, I don't think
Check for blood sounds actually.
Sure.
Do we have breath sounds?
Did you hear some narration?
Okay.
Bilaterally, or is it just one-sided?
You hear it bilaterally.
Okay, do we have any more EpiPens?
We do not.
Okay.
Okay, while we're, can we update mom of kind of what you're doing and give her a recap? Looks like he had some kind of allergic reaction. He didn't respond to medicines we had. We had to help him.
Does have food allergies for sure.
Yeah, so I think he had an allergic reaction to something. So right now the medicine we usually give wasn't able to take care of all the swelling. So we had to go ahead and support his airway because he wasn't able to breathe because all the swelling from his food allergies. Does he have any other medical problems?
No, that's it. Just food allergies.
Okay, so he's going to need to go to the hospital to continue to get more medicine. We've called 911 to see if we can to get an ambulance here as soon as possible. They'll have a couple more supplies.
This is Nurse Ratchet here with an update. So I'm on the phone with EMS. I told them that you did a needle crike. There is a adult trauma center 15 minutes away. The nearest pediatric institution is 1 hour away. They want to know where you want to dispose of. Give them a heads up.
Okay. So there's a 15-minute facility away, and then there's a pediatric center an hour away.
An hour away. I think we stabilized at the adult trauma center en route. I think this kid's still unstable to travel an hour, assuming his vitals don't improve by the time EMS gets here. So let's call both transport teams and get the children's transport to meet at the adult hospital. We'll do a quick kind of stabilization and then ER transfer.
Okay.
And let's run this by the PEM attendings that are working at the hospital as well.
Okay. And you notice your bagging and the chest seems to be really hyperinflated.
Okay. We can unhook.
Unhook it, let the pressure out. All right.
So we're decompressing the chest with it pulled off, and we're gonna let the paramedic bag. We'll do a rate of 16 to start with. You cool with that?
Yeah, that sounds good to me.
So we can offload that.
All right.
All right, and we're done.
Judges, take it away.
UT Southwestern, how did that go for you? So scary. Baby is turning blue, 70%. You're bagging. What were your thoughts? What was going on? I think you guys are muted. Oh, we're muted again. What happened?
Sorry, we're messing with our sound. Can you repeat your question?
Just, you were bagging, the baby was blue, 70%. What were you guys feeling? How are you feeling?
Yeah, we were pretty concerned that the interventions we were providing thus far were clearly inadequate and we needed to take it to the next phase. We were unable to intubate because we didn't have the essential equipment. There was no laryngoscope and we were going with an ET tube that we didn't know was sterile. I mean, it's not a sterile procedure, but we didn't have enough equipment certainly to obtain a definitive airway. So the only alternative was to cry. Certainly the emotions were high. It was a tense situation. But we didn't know that we had the equipment to do a crack until we opened the box and discovered it.
Awesome. I think it's always a very difficult decision to make, especially in a kid. So kudos to you for making that decision. I love also just want to make a comment to the person who like updated mom was so calm and so nice. Mom, this is what's gonna happen. I just love that, right? Because mom's probably freaking out in the corner. So great job. I really, really love the teamwork in this group. So good job, Dr. Griswold.
Yes, I would echo all of that. And we always try to do a decent amount of pre-briefing for our actual learners in SIM, but this is so different and so out of that element. But why don't you guys tell us about the experience, what you went through? Again, just because we're short on time, knowing what you know now, would you do anything different, right? So just a little bit of your reactions to the case, and if you had it to do over in another 8 minutes or whatever, what would you do differently? Because I think you perseverate on these things a long time too, because you did the experience.
So I think that it would have been nice for us to recognize the need to cry a little sooner. She desaturated down to the 70s before we made that decision finally. It would also have been helpful for us to realize that we could crack open the EpiPen for a second dose. I don't think it would have changed the course. We would have ended up in the same situation either way. But definitely a positive learning point for future episodes where we're picking up our kids and they go to anaphylaxis.
Yeah. Even adults too, you can crack that second dose out of an adult EpiPen too if you're on an airplane or something like that. But I absolutely want to commend the performance again of both teams, and I'll leave it to Dr. Falk for the final word.
Hey guys, hold on. My dog's about to bark again. Maggie, shut up. Sorry. So, I mean, I think like the last team, both of the teams hit the major teaching points, which is really great. And I wouldn't beat yourself up over the SAT getting down to 70%. The two crikes I've done in the real world, the first one, when you have to do it, you have to do it. But making that cut, making the first step in the process is terrifying. And especially since you've probably never done it before. So like I said, the first time around doing it, don't perseverate around that. I think both teams did a phenomenal job and hit the major teaching points. And I really want to give you guys a kudos to it and applause, because both of you did a great job. Quick point, I put it out in the chat. You know, to do a needle crike, you just need a 18 gauge needle, 3.5 cc syringe, and then the connector from a 7.5 ET tube. That's all you need if you don't have the jet insufflator. Thank you guys for putting up with us.
All right, so thanks to Jacoby and thank you to UT Southwestern. Chris, is voting open?
It is open. We're ready.
All right, I'm going to put the QR code back up on the screen for those that still need it. Team A is going to be Jacoby. The team that went first is Team A. Team B is UT Southwestern. A for Jacoby, B for UT Southwestern. And Chris, let us know when voting is complete.
Yep. A few more seconds here. All right, voting is closed, and our winner is Team B, UT Southwestern. We got some muted cheering back there from them.
All right, congratulations, UT Southwestern. So for the next case, we're going to invite Dr. Sarah Hawk up to give us a little bit of background. This was kind of a unique case and a unique way to do simulation. So I'll let her kind of bring it in, and then we're going to flip the script a little bit and do a bit of a debrief with participants before the case even starts. So Miami and NYU Bellevue, like both of your teams to turn on your videos, and Dr. Hawk, we'll turn it over to you.
All right, so case 4 was a little bit of a challenge. That was a different style. So I think both teams were a little bit surprised by the way that the cases needed to happen. Case 4 was a case writing challenge. So each team was provided with the Simwars case template and was given half an hour to write the case. And whatever was on the paper at the end of the half an hour was what we did in the sim lab. Then we went ahead at the Rush Sim Center and put the case on for a couple of unsuspecting residents and fellows. And you'll see that video today. So the rules for the case writing were they had to include 3 of the following items: flowers, Scotch tape, binoculars, 24 purple grapes, and a shovel. So I think that gives you an idea of what the teams were faced with. And I think we're going to hear from them a little bit about how that experience went.
Yeah, so the first case we're going to watch is going to be Miami's case. So would love to have the judges come back on for a minute, and we'll let Miami talk a little bit about how they approached the challenge and what their approach was to crafting and writing this case. And then we'll see how it plays out. And you guys haven't seen the case yet, so we're going to see how it actually worked. So judges, bear in mind that these folks may have limited experience in actually writing a case. So we've taken Simwars and kind of flipped it on its head.
Yeah, no. So I've seen that Andy Godwin is in the chat and everything. So it's really exciting to me. This was one of the most favorite Simwars I ever had the chance to actually participate in. Was actually making the case, delivering it, and debriefing it. It was amazing. So I know how hard this is, but tell us about what it was like to write a case in a half hour where you had to include things that have nothing to do with medicine.
You know, I think one of the most important parts is that we came up with a concept that unified the 3 or 4 different things that we needed to include in our case pretty quickly. And so once we came up with a set plan from there, I think some of the devil in the detail of executing the case and having different pivot points was more of a challenge in making sure that it was like cohesive, solvable, clinically relevant, and like made sense.
Is there any, can you share with us just one little snippet of what these guys are supposed to do in your case?
A little snippet, like spoilers?
Yeah, little spoilers, like give away what they're supposed to do, right? Because we're gonna watch it.
Oh,
right?
yeah.
So what did you want them to do?
So it involved a few different things, one of which I guess some of the main points would be that like the patient unfortunately was like passed out in a foxglove field. So that's kind of how we incorporated the flower element of it. So that had the cardiac component. Okay, so like foxglove or digoxin toxicity, then there was a concern about tetanus and vaccination because the child was unvaccinated. And so that introduces an important notion of having shared decision-making and educational discussions with parents who might have hesitations about that. And I'm sure anyone who worked in pediatrics or seen them has encountered that before. And then the third and final thing that we really incorporated was a foreign body, which was a grape, I believe, or several grapes. And so those are kind of the core components of our case.
Okay, good.
All right,
So
and with
Dr.
that,
Goldberg,
let's see how it played out.
Come on in. GMS just dropped off this little kid, and then they went away. They didn't give us any report or anything. Mom called apparently for respiratory stress.
Okay, good to know. Can we get this kid hooked up to the monitor?
Yeah. How old is he?
Do we know?
He looks to be about 1. Mom was gonna drive in.
Okay. Okay. Any activity? Hey, kiddo.
He's moving.
He's moving. Is he
Looks
speaking,
like he's having
talking,
a little
anything?
trouble breathing.
Okay. How are his lips? Any diagnosis?
It looks like us look okay. I mean, I'm getting a stat of 100. The EMS, they dropped off his shovel. And do we know anything about the shovel? I no idea. Like he was just kind of. So he has bilateral breath sounds.
Okay.
Yeah.
Okay. So bilateral breath sounds.
But I did hear a little bit of stridor. I don't know.
I hear a little bit of stridor.
Yeah.
Okay. All right. I would like to look in the mouth. Just kind of quickly. Do I see anything in the mouth?
Do you see anything in your mouth?
Let's see. I see what looks to be a grape in there.
Okay. That is not ideal.
Okay, we're gonna try to get that out. All right.
Hey, buddy.
Let's make sure we have respiratory equipment all set up.
Yeah, EMS put an IV in.
Perfect. Yeah.
So, do you need like this stuff?
O2 monitor. Smart grip purple.
You got all of this.
Perfect. Thank you. But in the meantime, I'd like to try exactly before we do an IV or anything to breathe the child out. So
stats are at 89%.
Slip, grapes out.
Oh, great job.
Can we keep checking the stats? Looks like it's going up a little bit, but
do you want to get like a
let's
number read?
yeah, let's supplement.
Hi guys! Oh my gosh! Little Tommy! Is he doing okay?
Hi, Mom.
Right.
My name is Brad Scott. I'm going to talk with you over here.
Okay.
Yes. What's your understanding? What's going on so far?
He just
blood pressure's still
he kind of
low.
seemed like he fell down while we were in the field looking at these beautiful flowers.
Do we have the number breather on already? So another episode
let me get him a number breather.
Walking the flowers. Walking to feel the flowers and then fell down collapsed. Okay. So that's what we heard. Okay. No specific report of trauma, no specific report of any
I guess
ingestion
secretions, what are we seeing when we look at this kid?
No secretions. No secretions.
Mom, does he have any allergies?
Any decrease in stridor after
He's not allergic to anything.
A little bit, but still. You have medical problems, mother?
No medical problems.
Okay. Gonna take a look at everything. Any
No
rash, signs of trauma?
There's this thing on his shoulder.
Oh? Okay.
It looks like a cut.
Laceration?
Yeah, and he was found next to this shovel.
Okay. Let's make sure that he tetanus shot. Is this what could that be?
I think that's his cuddling shovel, maybe. He's hypothermic.
He's losing. So let's try to get the fluid. Yes. Through the IV, please.
I mean, the flowers are so beautiful. I think.
Do you have any
pictures
pictures
of them? I don't have any pictures, but they look kind of like a pup, and they were purple. Oh.
Okay. So we might potentially need to do some tox stuff because this could be a tox case.
You want to get a bolus in there?
Let's get a bolus in the meantime.
What's going on with Tommy? So when we met him, we realized that there was a grape in his mouth. Oh. I don't think that was probably good. But we took it out. Then he was breathing well, but I think he may have eaten a flower like messing with his heart or his blood. Oh my goodness, he eats everything. He eats everything. Yeah. Okay. Yeah. So some of the flowers have some toxins in it, so we're concerned that he didn't eat a toxic flower. Oh my goodness. Okay. Do you save him? We're gonna work on my baby back. Okay, I'm gonna call my husband. Okay. updates from the mom. Of the mom,
Yes,
you
please.
eat everything. Like you eat like a cup flour that's purple.
8 cup flour, okay.
Okay, which flour is your salad?
So similar things are kind of like a wide complex tachycardia, which is not really what we're seeing here. Or no, it is what we're seeing. Okay, yeah, so he is tachy
And
and
hypotensive.
hypotensive. Okay.
All right, so we have the fluid going now. The oxygen saturation is up. He's still very tachycardic. We can try some Zoxyn antidote right now. Okay. Get some vials going in the meantime.
Okay.
You have one IV right now?
Yeah, I have one IV.
Okay.
And also get a bigger stick glucose for this.
I pulled it off the IV. It's 86.
86. And then any temperature right now?
Normal.
Okay, sounds good. Otherwise, once we get that bolus in, we'll recycle the blood pressure. Can we also try to do a vial of Digivine, please?
One vial?
We'll start with 1 and we'll try to go up to 5.
I took a rectal temperature, 37.3.
Okay, cool. Okay,
gotcha.
All right, so 1 vial of Digivine,
start
and
with
after that,
one.
then we talk toxicology.
Yeah.
Okay.
Tox or poison control or pharmacy to confirm dosage, but we'll start with this initial vial.
Excellent. And then can we recycle the blood pressure, please?
Digivine is in.
Okay.
Yeah.
You just have to push the button on the screen. Oh, cool.
Which one? For the function?
The blood pressure. The third, the 3, the 1 on.
Third.
This one.
Sounds good. Any secretions that are coming out? Any issues with people? They're feeling pretty dilated bilaterally. Okay.
Maybe a chest X-ray and a soft tissue neck while we're waiting for things to.
Okay, I'll ask them to come and do that.
Thank you.
Sounds good.
Blood pressure should be improving slightly, but still pretty low. So the CC is good. Perfect.
Okay, so we got our fluid bolus, a little bit fluid responsive, looks like.
Yeah.
But still very tachycardic.
Exactly.
Oxygen saturation is doing a lot better.
Agreed.
Did you need me to send any labs?
Can we send a full panel, please, including CDC, BNP? We'll send a UA if we can get one. We'll send serum tox. We'll send
Digoxin
level as well.
Okay.
All right, this is Tox. Hey, Tox. We have a 1-year-old little kid coming in via EMS. History provided by mother is that he was in a field with some colorful flowers. Looks like it might be Digoxin poisoning. He also has a break on the left arm. Hemostatic at this time, but we're concerned for Digoxin poisoning. He came in pretty hypotensive, tachycardic, wide base. We've given him 1 vial of Digivine. We've given him a fluid bolus. He's mildly responsive, but still a little hypotensive. Saturation is improved with non-rebreather. We're wondering what the dosage may be for Digivine, given that this could be a tox syndrome.
Oh yeah, no problem. We looks like the Digivine should come actually in these like 3-cent vials. You can go ahead and get them another. If he looks like he's improving with the 1, I should probably find to come on into the tissue.
Okay.
What did EKG look like?
EKG was wide base tachycardia. It's a little hard to interpret, but it's definitely very wide. I'm not really seeing great QA, to be honest. Seeing potentially even some weird deep Qs in D1 through 3.
Oh yeah, that makes sense.
Yeah.
Okay. Yeah. So just go ahead. You could probably have me get them to take you. We can kind of continue with the Digivine. We probably get 1 more vial.
Okay.
Continue on about it.
I appreciate it. Thanks so much. We'll follow up with you afterwards. So can you try 1 more vial of Digivine, please?
1 more vial?
And then can you call the PQ? We definitely like to get this kid admitted in admission line.
I'll paste the PICU for you.
Case your pads on just in case. All of labs.
And then after this Digivine is given, after we draw this first EKG, after the patient comes around, we'd like to get another EKG, please.
So radiology called and said there's unilateral right side emphysema on chest X-ray.
Okay.
I think radiologists having trouble seeing which image this is on, but it's the unilateral right sided emphysema that is there. But I can't get it to cross over in PACS right now. So you're just gonna have to take my word for it.
No problem. Anything of the soft tissue of the neck at all?
It's on the right side.
Okay.
That's okay. Gotcha. So, some right-sided issue, potentially would need a bronch.
Exactly. You might have
possibly
issue, probably with the rate. Yeah. Okay.
Right now, respiratory status is stable.
Exactly.
So I think until they're working, they have to be stable. Yeah, maybe hold off on intubating. But
exactly.
We call pulmonology. We'll call pulmonology.
This is Paul. I also run the ICU.
Thanks for taking Paul. We have a kiddo in the ER who came in with a likely toxic syndrome with Digoxin poisoning, who is saturating well now, but has a right-sided epithelial picture seen on X-ray. We're concerned for possible foreign body in the right main stem. We did pull one grape out with improving the saturation with face mask, but still we are concerned with this right-sided epithelial. We're concerned that he might need a bronchoscopy.
Okay, yeah, sounds good. Yeah, we'll take notes and figure it out. All right, thank you.
Thank you.
All right,
End
that's
case.
the end of your case.
Good job.
All right, so that was fun. So now we're going to have NYU talk a little bit about their case that they designed. We'll watch their case and then we'll kind of sum with both teams together. So we'll let the judges take NYU through it.
Yeah, so just NYU Bellevue. Again, we'll do the debriefing of both teams together this time, but if you can just prepare us with the learning objectives that you had set up for the team and just a little bit about what this experience is like, and then we'll do the whole group debriefing.
I'm feeling shook right now because we also did a digoxin case. We had a lot of fun coming up with a story. Our idea was that it was kind of like a trick. A person was found with a shovel nearby and was brought in as a trauma. And it was kind of also later on that you found a flower in the mouth and you had to figure out that the vital signs were not quite consistent with trauma and were digoxin. And it was definitely something that none of us had ever done before and was really challenging to do in 30 minutes. But our team leader, Laura, did a really good job like giving us all tasks to work on just so we could be doing things in concert. But even still, it was really challenging to get everything done in time.
Yeah, it was a difficult task and it was definitely unexpected for us. Given the objects that we had and being NYU Bellevue, we definitely wanted to do a tox case, but we wanted to do a tox with a twist. So we kind of wanted to do an undifferentiated trauma. So we tried to use the shovel as kind of a red herring that someone was maybe attacked with the shovel, but really the case was a digoxin overdose as well. So we tried to have our learning objectives as learning to recognize, change the mental mindset between having a medical case and a trauma case, and two, realizing early digoxin toxicity with a changing EKG and being able to intervene early with digifab.
Okay, great. All right, let's see it.
Yep.
Hello.
Hi, yes, I'm EMS. I have a patient, a 46-year-old male coming in after a presumed assault. He was found down in the garden with a shovel next to him. Wife was on the scene initially. She says that he was out bird watching, and then when she went to check on him, she found him laying on the ground acting strangely. She thinks he was probably attacked by one of the neighbors. She's on her way in a car, but separately. We put him in seat collar, brought him over here. He was kind of respirating on his own. Heart was a little bit on the slow side, around like 45 or so.
Yeah, you must get this strip.
Oh, okay.
Okay. And he was gardening, like in his own garden?
Yes, he was in his own garden at the time.
And I'm your nurse for whatever you need.
Gotcha. So let's go ahead and make sure we have IPS as established for this gentleman. We'll make sure he's hooked up to the monitor.
I'll get a lamp for him, yeah.
Perfect. And then, sir, hi.
I'm just gonna move your binoculars, buddy.
Hey. How's it going, bud? Can you talk to me? Okay, gotcha. So he's not really fully with it. We can particularly our GPS, but let's fully expose him. Let's grab a stethoscope. Okay, just grab your ears. Let's just listen for breath sounds. Check for peripheral pulses here.
So primary survey, trauma.
Yeah.
Airway, breathing. I guess this is
He's
his
talking.
shovel.
We'll see if
I'm just gonna move it. Is that okay, guys?
Breath sounds are equal and bilateral. If he came with this shovel and
these binoculars?
with these binoculars.
Yeah, I guess these are the binoculars from
Okay.
the one who was bird watching.
Gotcha. How are our pulses here?
Secondary.
Yeah, that's right. For
Do we have a
See,
monitor? Yeah.
perfect pulses. Let's go ahead and get him hooked up here. Get a set of vitals, and while we're going through that, I will check my light here. Check these pupils. People are reacting. Hopefully.
Is there any head trauma that we can see? Any blood?
Head trauma signs of
I
trauma.
really don't see any trauma. I don't know where the wife got the idea that the neighbor attacked.
Looking at this shovel, is there any blood or
No blood on the shovel. Oh my gosh, this is my husband.
Hi, ma'am.
My husband. Hi, let me talk to you after.
Yeah.
They really do. Like just, I
So-
just, they
And
must
then
have
anything else
that.
in terms of
He
chest
was
needs
out there with his bird watching binoculars.
Oh, okay.
And he must have just gotten whammed by them. Did you see him? No, no, they must have run away with like. Oh, okay. But he was, he was doing that.
What's the family's please? Can we get some pads? Yeah, some casing pads, and we also do have a blood pressure. 140/80. Okay, 140/80.
Any saturation?
Oxygen saturation 90%.
You can get me.
Not yet. You're supposed to run right now.
Go ahead and get an EKG, a chest X-ray, a pelvic X-ray. We also need to go for a CT scan of his brain.
I really think that neighbor just messed him up.
Okay.
Do you have any collateral? Like who EMS brought him in? Was there anybody with him at the time?
No.
No external signs of trauma. Yeah, exactly. So like it's good.
You know, he was in a field full of flowers.
Oh, flowers.
He's in a field full of flowers.
Okay, gotcha. Let's do atropine then. Yeah. So he's
Did you want to
symptomatic
eat
bradycardia. We do.
This is the.
This is EKG or this
Yeah.
is stroke? Okay. So this is tacky, but I don't really know what to make of this. Yeah.
Okay, why don't we do actually?
I was just gonna say, let's go ahead and do the atropine. He's actually decreasing right now. So let's.
Okay, I'm gonna go for grab that.
I guess we consider spacing. If we
Oh,
need.
Transportation,
So sorry.
We can.
And what would be the antidote for like?
Oh, so we could potentially do. So first of all, does he have like increased secretions or any other kind of dumbbell?
0.5 of atropine. I hope that's what you wanted because that's what I gave.
A little bit increased secretions. Okay, so we can treat them for that. So we would potentially use 2-PAM. We would also use atropine as needed to clinical effect, so we can continue to give that. But he's not very sweaty. He's not.
His phone had a lovely picture of the flowers. You guys, look at what he was seeing in the video. Is it pink? Yeah, it's purple. It's purple.
Oh, is that
Isn't that
Foxglove
beautiful?
is the Johnson? Okay. That's crazy. Okay, so we can do Digivine potentially. Let's call poison control and let them know, but I'm sure they'll be busy. So let's go ahead and treat it ourselves.
Okay, poison center. We'll get them on the call.
Excellent. Okay.
You said Digivine. How much do you want?
I think it's 5 to 10 vials.
I have a line over here.
Right.
Can we get Digivine?
Let's
Digivine?
do
Yeah.
5 vials.
I gotta get it from pharmacy. 5 vials. Is that like a dose?
I think so. That's
Okay.
yeah.
We can always call time.
Yeah, exactly. That's why I would talk to pharmacy. But I think that's
Do you
what
guys
it
want
is.
to
Can we try? Yeah, see some atropine.
Yeah. Do we have a recycled blood pressure? Recycled blood pressure 160. Okay, so he's decreasing. So yeah, we can start to transcutaneously pace.
Do we have the?
Hey, buddy, are you still awake?
And then
Sir? So we're gonna try to get his probably should for something for.
Okay, so we can do 50 of fentanyl, and then also let's get some blood work.
Did you what? I have some Digivine.
Let's give
Is
that.
that
That's the treatment.
That's
So
fine,
let's go
okay.
ahead. Let's go ahead and give
all
it.
right? I'm gonna go ahead and put this right
Yeah.
here.
Beforehand, we can have drawn off a ditch level, but it's not really going to do anything. For
Oh
us.
yeah, I drew off some labs. So do you want me to send them?
Digoxin, CBC, CMP, troponin, DDG lactate.
Okay.
Do a serum tax just in case, fill that on as well.
Okay.
E2H level.
Okay.
Great.
No problem. No problem.
Cool.
Any changes in this one?
I don't think so.
That was only 1 vial, so I'm gonna keep giving a vial. Okay. Just 5 vials is a lot. So
Yeah,
So we added to the
one Digivine.
excellent.
Personal temperature
came out at 98.7. Perfect.
And we get a glucose in between. There's vial. Yeah, I'll get it in a second.
So just to clarify, we have a 46-year-old gentleman. Do we have any past medical history for him for collateral? He's otherwise healthy gentleman coming in, no reported past medical history, altered mental status, found a shovel and some binoculars. We're concerned for symptomatic bradycardia, which we're treating with presumptive foxglove exposure. Other things we've kind of ruled out, since it's neuroglycemic. He doesn't really have any external signs of trauma. He's become more imitated. Hey, sir, what's your name?
Name is Jack.
Hey, Jack.
Did that neighbor attack you?
What's
Oh,
going on?
James.
Yeah.
No, you didn't do anything.
Hey, man.
Well, there was a shuffle.
Hi, are you the wife of our patient?
Yeah.
I am Dr. West.
So I think that therapy is effective. We can continue to keep an eye on him.
Well, I just found him lying in the field.
You know how long you've been in the field?
You left about half an hour before you found
Hey, sir, you're at Rush.
Nope.
We're just, you were passed out there. We're concerned that some flowers might have had a bad reaction. You remember anything that happened today?
I mean, I was just doing a little gardening. I saw beautiful roses there. I hadn't seen them before, so I decided to kind of give them a little sniff. Yeah, my wife plants them a long time ago. I just never saw them until now.
All right, well, we could do some medicine to try and help him feel better. You let us know if anything changes.
Yeah, he was just saying how I planted these lovely flowers. Yeah. So, yeah, I wanted to make sure that you saw the nice flowers.
You're number one.
Oh, there's toxic?
So I think his rhythm is stabilized. Yeah, it's going to repeat EKG now.
We're going to repeat EKG. I'll send her one.
Flowers and yeah, other than to consider.
I don't have one yet. Go ahead.
Hyperkalemia would be a consideration for this as well.
Any labs back from what we drew a little earlier?
All right, it's there.
Oh, we're done.
Oh, good job. That's the end of your case.
All right, judges. So we'll let you guys talk to both teams about their experience and having their cases translated into action.
Both teams, wow. I was just looking at this list of 5 things and thinking of like the show Chopped, like a mystery box, and be like, how the hell am I supposed to put this together? But I do agree. I think something about flowers always makes EM people think about digoxin for some reason. So I totally agree with that. So both cases were about digitoxicity. Starting with Miami, now seeing your case played in real life, how did you think about the progression? What were some of the things that, you know, didn't go quite the way you thought it was going to go?
I would say the X-ray. I mean, one of the interesting components that we had to incorporate was not just one, but like 30 grapes or something along those lines. There was several different grapes. And so kind of balancing between how we would incorporate more than one. So, you know, they had removed one, and then our thought process would be like they would have, you know, the X-ray would have been before the diagnosis. And then in the way that it played out, the X-ray showed that there's still like unilateral right-sided emphysematous changes consistent with like no removal of the foreign body quite yet. So that was an interesting wrinkle. But, you know, just having gotten those 3 things incorporated, it was cool to see a case executed. And I thought the fellows did a great job.
Anything else from the team? Was there anything else surprising or pretty cool about how the case?
Having the shovel there, like, was pretty neat. It was like patient, like Brazil tape shovel, and it was like
shovel,
an interesting,
as big as the baby shovel.
Yeah.
Cool. Similar question to the NYU team. This case was really interesting because I think the fellows went down a little different of a path than you initially intended. So, what were your thoughts? How did that work out for you?
Yeah, I mean, oh, sorry, go ahead.
I was gonna say, I actually think it went pretty well about how we intended. I mean, the shovel and the trauma definitely was distracting, and the team was very focused on a trauma at first. So we were happy with that outcome, the way it happened, and then how the bradycardia did tip them off. Something that we thought might happen was that they would be concerned about a Cushing's reflex with the bradycardia and the trauma, which the team didn't recognize or think about. But overall, I think that they executed it really well, and the fellows did a great job. What were you gonna say, Rachel?
I love that in your case, obviously the Oscar needs to go for Dr. Sarah Hawk for her amazing acting ability. Amazing. This is probably your 15th career if you're interested in taking this on. But she was like, look at these flowers, they're amazing. And I really think that kind of tip them over from like a cholinergic, because I really thought they were going down a cholinergic pathway, right? And then it was like until they saw like these beautiful purple flowers. And I think that's why your stimulus were amazing. I just looking at your case, how it was laid out, I really like that you went through the time and effort to actually put the flower together so that Dr. Hawk could be like, look at what my husband took a picture of. It's so beautiful. So I really think that really helped your case a lot. So great job, guys. Really tough, weird mystery basket, but great job. So pass it on to Dr. Hawk.
Yeah, Dr. Hawk, you had the benefit of putting this together for your fellows.
You want me to go next? Yeah,
yes.
I'd be happy to. Yeah, so we were so excited to hear the 2 cases, and my fellow was helping me run the mannequin, and then there was 1 fellow and 2 PGY2 residents from 2 different programs who were volunteering to kind of be part of this this case. So I think they did do a really great job in both scenarios. And I think as we were running the cases, we were like, oh shoot, there were a couple of things that were that probably you didn't have time to flesh out all of the parts of the cases. And I think the things that Miami did really well was you had multiple key vital abnormalities on the kid, you had really clear transition points, and you had critical actions for every portion of those transition points. But then I didn't catch on to the tetanus part being like a thing I was supposed to emphasize as either the nurse or the mom, because I probably would have if it had been emphasized in the global like critical actions, which were a little bit less fleshed out for that case. There was also a portion where the patient was supposed to require intubation if things were not going well, but I wasn't sure if I was supposed to make them intubate or not make them intubate. And so that's a challenge when you're writing a case. How do you want to guide the participants? Do you really want them to intubate in this case, or do you not? And so that was something that we struggled with a little bit, but once the grape had been extracted, I was like, I can't really make the patient decompensate more, because there's nothing that I was aware was supposed to be in the airway that would make that happen. And so it might have confused the people doing the sim. On the other side, for the NYU Bellevue case, you guys focused a lot on the overarching objectives and fleshing out like the things you wanted them to accomplish. But there was a lot less in the way of like specifics of each transition point and vital signs. So it made it a little bit harder to make sure we were doing the case the way you wanted to. But I think the things that you included instead of fleshing out that portion of the case were like the photo, and both teams included great EKGs for the residents and fellows to kind of take a look at. So I think those are some of the things that were most challenging as we were implementing the cases, but really excellent job. And we had a lot of fun implementing the cases that you wrote.
So again, I think this is really great. And again, kudos to both teams with the unexpected curveball in 30 minutes to put these together. And I really do think this is an amazing test of your experiential learning and simulation education savvy and skills. So thank you again for participating in this very different one. But we're going to move to voting. Unless someone else has something else they want to add.
So Chris, I think we're good to load up voting.
Open.
Great. So voting is open, and just to refresh everyone's memory, Team A is going to be Miami and Team B is going to be NYU Bellevue. And Chris will let us know when voting is closed. There was a request to give a few extra seconds on the last round, so we'll make sure that everyone has time to get their votes in.
Looks like we have, let me get 10 more seconds here. Oh, hang on, a couple more coming in. All right, we'll close it out. And the winner is Team B, NYU.
All right, congratulations. All right, so that concludes our prelim round. We're going to move into the semifinals. And for the semifinals, we have WashU and UF Jacks are going to be competing in the first semifinals case. And we're going to have Dr. Bear come on and give us a little bit of background about what we're going to see.
Sure. Can you hear me okay?
Yep.
Excellent. So for the next round of the semifinals, we worked with just Sage Wexner from Kern, as well as Scott Goldberg from Harvard, and then the Mount Sinai division. The next case is basically charades, as has been done in the past. So I just wanted to mention Dr. Wexner's marketing team made a pretty cool page for them to read it, and essentially created some cards. So I just wanted to give you some of the information that the team was given, some of the pertinent parts. So each team received this notice. You have 100 seconds to earn as many points for your team as possible. There are 4 decks: red, blue, green, and yellow. Each has a specific theme that you can try to guess. For example, the yellow deck was diagnostic findings, and then the other 3 decks presenting concerns, procedures, and diagnoses. Moving forward, each team was to arrange themselves so that one person was in the hot seat. Thank you for putting those up. I was going to, that's perfect. And with the first envelope in front of them. And each, just so it's clear, the order of the decks was already, we made sure that each team had the same order of decks, so there was nothing that was different. And that the cameras, essentially, there were 2 shots of the cameras, which you'll see, one that we did, as well as one that their assistant took. So the person in the hot seat looks at the first card without making any sound. They act out the words in the cards, and they try to get the other 3 team members to guess. If they guess correctly, the judges will let them know, and they can move on. If they so choose, they can skip as well. Once the card is skipped, they cannot go back to that card. So just one of the points for strategy. No noises at all. 1 point per card, 100 seconds, 4 decks, 1 team member for each deck. Those are the basic rules. That's it.
Great. So for those that are familiar, this is really similar to like Taboo, the game, where you're basically just trying to get your teammates to guess what's written on the card. So again, we have WashU and UF Jacks are the 2 teams. You guys can turn on your videos if you want. WashU is going to be up first. And just so everybody knows, there are actual points for this, and we'll share the points afterwards. But first, we'll just enjoy the game. So, WashU is up first, and here we go.
Go. And
Chest pain.
Yep.
Heart attack. Am I? Oh,
stab to the heart. Chest. Beck's triad.
Oh,
laceration. Knife wound.
What is it called?
Knife. It's a stab wound.
Yes, go.
Throw him on the ground. Seizure. Dizzy.
Yep.
Concussion.
Vertigo.
You got it.
Yep.
Already got it.
Back pain. Kidney
Back pain.
stones.
Good.
Yep.
Chest pain. Vomiting. Retching.
SBL.
Poorhouse.
12 bowel obstruction.
Diarrhea.
Gastroenteritis. Diarrhea,
gastro.
vomiting, GI bleed.
Upset stomach.
The abdominal pain.
Nausea, vomiting, gastroenteritis.
Nausea, vomiting,
Nausea, vomiting, diarrhea.
Yes,
Good.
got it.
Chest pain.
Shortness of breath.
Oh,
Yes, got it.
earache. Vertigo.
Ear pain.
Keratitis media.
Tinnitus.
Cerumen.
Foreign body in the ear.
Yes.
Good.
Double vision. Blurry
Diplopia.
vision.
Good.
Got it.
Pregnant.
Cramps.
Menorrhagia.
Oh,
bleeding.
vaginal
bleeding. Pregnant.
Torsion.
Uterine prolapse.
Vaginal discharge.
Pelvis.
Pelvis.
No.
Your UTI. UTI.
Okay.
Urinary
Pelvis.
retention.
Yeah.
Good.
Oh. Oh,
Shoulder
shoulder
dislocation.
dislocation.
Good.
Yes.
Time. Time.
Incontinence.
Are we ready? Set. Go. Oh.
Chest
Chest.
pain. Chest. MI.
Chest.
Defibrillation. Angina. Or aortic dissection.
Stab wound.
Stab wound.
Crank. Tracheostomy.
Sternum. Esophagus.
Heart. Lungs. Intubation. Shortness of breath.
Main stem intubation.
Cavitary lesion on chest CT. Shortness of breath.
Short of breath.
Pneumonia.
PE.
Oh,
Pulmonary embolism.
Pulmonary
Good,
embolism.
good.
Okay. Diagnosis. We got it. Appendicitis.
Good.
Sore throat.
Ludwig's
can't breathe,
angina. Anaphylaxis.
Pharyngitis.
Angioedema.
Epiglottitis.
Good.
Edema.
Good. Good. Yes, you got it.
Yes, she said
You
it.
got it. Go. Go. Go.
Yeah. Just go. The same thing.
Angioedema.
Ludwig's
Foreign
angina.
body.
Anaphylaxis.
Good.
Yes.
Oh, you can skip it if you need.
She skipped. Albuterol
Asthma-
here.
asthma
Asthma
exacerbation.
Asthma
exacerbation.
exacerbation. Yep.
Lungs.
AAA.
Aorta.
AAA.
Good.
Yes.
Abdominal aneurysm.
Yeah. Headache. Migraine. Migraine.
Aneurysm
Subdural.
ruptured.
Subdural. Epidural.
Good.
Epidural.
Headache. Syncope.
Traumatic.
Stroke.
Yes.
Good.
Oh my goodness. Alligator.
Shark bite.
Yes.
Oh my goodness.
Time. Time.
Kidney stone.
Say go when you're ready.
Go.
Hip.
Shoulders.
Hip dislocation. Reduction. Hip reduction.
Yes.
Chest.
Defibrillation.
Yes.
Cardiac defibrillation.
Good.
IJ. Essential line
IJ.
placement. IJ. Oh.
Transvenous spacer.
Yeah.
Transvenous spacer. John.
Pericardiocentesis.
Yes.
Yep. In it. Intubation. Intubation.
Yes.
Good.
Shoulder dislocation. Shoulder reduction.
Yes.
Good.
Oh no, just do it. You got it.
Peeing. Foley catheter.
Foley.
Catheterization.
Oh,
Bladder
rectal
catheterization.
Skip.
Yep.
Skip.
Oh my gosh, no. We run and roll.
Bla-
DPL. No,
paracentesis.
paracentesis.
Cesarean section delivery. Ultrasound.
Umbilical cord catheter.
Good.
Yes.
Yeah.
Yes.
Yeah.
Chest CPR.
Good.
Yes.
IJ. Central line placement.
Good.
Yes.
XLAP. Cesarean section. Thoracotomy. XLAP. MBC.
C-section. Yeah, what is it? Postmortem C-section.
Postmortem C-section.
Postmortem
Yes.
C-section. No, yeah.
She gave it.
Yeah. Oh, right. Hey. Perimortem.
Cutting.
Fasciotomy.
Lesion. Bleeding.
Tourniquet.
Arterial bleed.
Tourniquet.
Venous
Skip,
bleed.
skip.
Venous cut down. Oh, venous cut down.
Time.
Thoracotomy.
Time.
Thoracotomy. Whew. Yeah. There you go.
Diagnostic findings.
Diagnostic findings. Okay, we ready?
Yes.
Okay, go. Oh my.
It's okay.
God.
Just throw it on the ground.
Oh, no.
You can skip.
She's gonna skip.
You got it. It's okay.
Oh, okay.
X-ray.
Perforated.
KB.
No,
Hair under the diaphragm.
Yes.
Oh. Okay.
Eyes. Slit lamp. Sleepy. Palpitations.
Fluorescein.
Cardiogenic syncope.
Oh, but it's a diagnostic.
Eye. No.
No.
These are hard.
It's okay. CT scan for a stroke.
Um,
Head CT. Peeing. Okay.
Stick.
Urine. UTI. UA.
No. Okay, skipped.
What's
NPH.
it?
Oh.
Finger stick glucose. Hypoglycemia.
Good.
Yes.
X-ray.
X-ray.
Breast. X-ray.
Pneumothorax.
Yes.
Good job. X-ray. X-ray. Why
Why
do you
did
need
you
a sign
sign
them?
Good.
Yes.
Okay. Ultrasound, kidney ultrasound.
Right
Fast.
up quadrant.
T.
Positive, fast.
Positive, fast.
Good.
Yes.
Skip. Oh man. Wow. Okay. Back. CT.
Sciatica.
MRI. MRI for
Cord
caudacoid.
compression.
MRI. Epidural abscess.
Yes.
Good job, Val. Okay. Baby. Ectopic pregnancy.
Good.
Yes.
Oh God.
Time.
Baby. Ultrasound.
Time.
Oh, aortic stenosis. That's okay. Anemia. Hyperkalemia.
All right. We'll give you the scores afterwards, but we'll let the judges debrief.
I can start it off if that's easier. Yes. No.
Go, Dr. Bear.
Oh, okay. So, knowing ahead that you didn't know ahead of time that you would be doing charades with a completely different type of a setup, right? Where one person is in the hot seat needing to communicate to the rest of the team instead of the team communicating to the team leader. And also knowing that this is nonverbal is sort of throwing everything upside down for you. So I'm wondering, what was your strategy, both, if you had one, for both communicating and for passing, knowing that passing means that you're giving up the point for good?
I don't know that we really had a strong strategy going into it. I think one thing we thought about was that it definitely helped that we were all from the same specialty. You know, these are words and phrases that we're coming across every day. So that definitely helped. And skipping, I think if we as the card person didn't have a good idea, we just knew that it wasn't going to happen, so we bailed.
And then the second question that I'm wondering about is if you were to do this over again, is there anything that you would do differently?
Well, I think Jenna probably wouldn't have seized on the cable cord and ruin our internet connection.
Definitely. Another thing I thought about was I had multiple bladder etiologies, so maybe I should have tried to first do better at localizing, making them know that it was what organ I was talking about before I go on to, what was next. But other than that, I thought we communicated well.
Quick question, did the categories help you guys in kind of?
To be honest, I don't think
helpful, but then sometimes I'd forget what category we were on and get thrown off still. So when you could remember what category you were on, it's super helpful.
It seemed like super fun. This probably would be a great drinking game, I feel like. And I think my favorite charade was definitely Shark Bite. I was like literally on the floor. Hilarious. Yeah, you guys did a great job.
Thanks.
Thank
It was a
you.
lot
It
of
was
fun.
really fun.
Thanks.
Yes, and I would echo that with the creators and the just the amazing concepts. I would love to have this be a game that all the EM residencies can play. We all need some downtime and laughter, and it was hilarious to watch. So thank you.
Maybe like intern orientation game kind of thing. So fun.
All right. Thanks, Washu. And up next is going to be UF Jax.
Go. Heart attack.
Justin.
Good.
Gavin.
Good.
Yes.
Caesar.
Good.
Yes.
Izzy.
Yes.
Back pain.
Backman.
Good.
Yes.
Vomiting. Diarrhea.
Diarrhea.
Gastroenteritis. Yeah.
Vomiting and diarrhea.
Nauseous. Short of breath.
Yes.
Earache. Foreign body.
Tinnitus.
Good.
Yes.
Blurred vision.
Good.
Yes.
Can't
Bladder
feel.
incontinence.
Urinary retention.
Good.
Yes.
50 seconds left.
Shoulder pain.
Shoulder dislocation.
Yes.
Dysuria.
Yes.
Yes.
Drunk. Intoxicated.
Yes.
Last night. Abscess. IV drug use.
Bite.
Spider. Spider bite.
Good.
Yes.
Trigeminal neuralgia, shingles.
Shingles.
Rash, dermatome. Chickenpox, varicella, shingles. What do you? Skip.
Amputation.
Toe.
No amputation.
Yes.
Time.
Area.
Oh.
Go.
Shoulder.
Okay.
Asthma.
Pulmonary embolism.
Good.
Yes.
Torsion. Very torsion. Testicular torsion.
Appendicitis. Yes.
Good.
Yes.
Injury.
Good.
Yes.
Short of breath. Anaphylaxis.
Good.
Yes.
Mask.
Oxygen.
Short of breath. Hypoxia. COPD. Hypercapnia.
Non-breather.
Next.
Skip.
Those are diagnoses.
Yeah.
So
Asthma.
ACS.
Yes.
COPD. Asthma.
Exacerbation.
Pneumonia.
Good.
Pancreatitis. Hernia. Hernia.
Ulcer.
SBO. Cholecystitis. Jackal. Syncope.
Stroke. Vertigo.
Passing out. Loss of consciousness. Fall.
Head injury. Trauma.
Subarachnoid hemorrhage.
Epidural. Subdural.
Arrhythmia.
Yes.
Stroke.
Yes.
Bite.
Human bite.
Fight
Fight
bite.
bite. Bite wound. Cellulitis.
Oh my god. Animal bite.
Rabies.
Puncture wound.
Dog bite. Cat bite.
Tetanus.
Gator bite. Shark bite.
Good.
Yes.
Time.
Oh, that's kidding.
All right, you guys ready? All right, we're gonna go ahead.
Start.
Hip.
Dislocation.
Captain Morgan.
Reduction.
Captain
Yes.
Cardiovert.
Suppression.
Defibrillation.
Defibrillation.
Yes.
IJ. Pacer.
TVP.
Transvenous pacing.
Yes.
Chest tube. Pericarditis.
Paracentesis.
Good.
Intubation.
Good.
Yes.
Shoulder reduction.
Yes.
Dick sulfide.
Dick sulfide.
Epley.
Epley.
Good.
Yes.
Okay.
Paracentesis.
Suprapubic cap.
Delivery.
Fair warning
C-section.
C-section.
Ultrasound.
Pass.
Chest
Chest
compression.
compression.
CPR.
Good.
Yes.
Central line.
Good.
Yes.
C-section. Premorbid C-section.
Yes.
Good.
Okay. Amputation.
What's the fasciotomy?
Fasciotomy.
Circumferential burn.
Venous cut down.
Okay. Okay.
Thoracotomy.
Good.
Yes.
Chest tube.
Good.
Foreign body removal from here.
Airwalk drainage. Airwalk debridement.
Good. Time.
Yeah.
Okay. What was the what?
That's gonna be tough. I'm not sure like this. All right.
It's upside down.
Good catch.
All right, and go.
Two up.
2.
Wedge.
Wedge and so. Belly, free air.
Swirl sign.
Good.
Arterial bleed. Yeah.
Flush.
Fistula. Blood loss.
PVT.
Hemorrhagic shock. God.
Skip.
Cancer. Foreign body removal. Something in the fingers. Don't know.
Skip.
These are fun. Chest. Pneumonia.
Lobar.
Cancer.
Cavitary.
Lesion.
Pneumothorax.
Good.
Yes.
Heart attack. Bilateral infiltrates. Hilar lymphedema. Sternal fracture. Pulmonary
Mediastinum. Mediastinum.
Widening spine. Yes.
Good.
Blank. Fast. Positive fast.
Yes.
Good.
Oh god. Sine wave.
Torsades.
Yes.
Good.
Back.
Lumbar
puncture.
Positive.
Time.
Epidural abscess on MRI.
Like what?
Yeah.
These are so hard.
Hyperkalemia.
All right, judges.
Again, I would just start by asking the team if you had a strategy for communication and for passing.
We didn't really have a strategy, but we're all pretty good friends and can definitely like get nonverbal cues from each other. So that really worked out well for us.
I think we figured out the category pretty quick, and then just because it was like, oh, chest pain, and then it was just, oh, this is chief complaints, and then a couple of times, like, it's on the procedure specifically, like if somebody had done one recently, we point to that person and do that.
Since I don't think that this will change anything because the scores are what they are, you said you think you figured out the categories very quickly. Would you like to share with everyone what the 4 categories were?
I think the first one was chief complaints. The second one was diagnoses. The third one was procedures, and the fourth one was exam findings.
Yeah, the red was diagnosis, the blue was presenting concerns, green was procedures, and yellow was diagnostic. Yep, just as you said. And then my second question is also, if you were to do this again, is there anything that you would change?
I don't think so. I mean, we did pretty well. Definitely big charades, man. So.
I think my one question is, what is that move for dysuria? What was that? What dance move was that?
Right, and we crushed it. We love it.
Super fun to watch. Super jealous you guys got to play that game. McRoberts, obviously both teams definitely did not want to give birth or anything like that. So pretty hilarious. And then for something so ubiquitous, COVID-19, really interesting. I think I as soon as you pointed to the mask, I was like, they're gonna get it, they're gonna get it. And yeah, I don't know. So fun. You guys did a great job. It was great to watch.
I definitely agree, and this is such an unusual component, and we know that our creators actually do have the scores, so I think we need a little bit of a timeout and decide here what we're going to do together. If you know, if we're going to have a vote and see from the audience what the audience has deciding the winner, or if you just want to take the scores for the most points earned.
Yeah, so we're just in the way we always do Simwars is it's always a vote. The scores certainly factor into it, but it has a lot to do with communication and how teams did as a team and sort of getting to their score. If we could have both teams come on, though, we'll give you all the scores before we open it for voting, just so you know, because we were keeping tabs on you. So for the first round, the diagnosis, Wash U had 9 points and Jax had 8. For presenting concerns, Wash U had 11 points and Jax had 15. Procedures, the scores were 10 to 13. And for diagnostic findings, Wash U had 7, University of Florida had 5, for a grand total of Wash U 37 points and Jacksonville 41 points. With that said, Chris, are we open for voting on the winners?
We are now open.
All right.
Who's which letter here?
Oh, I'm sorry. A is Wash U is A.
Got it. Thank you.
You can start the voting over again.
I can do that. Let me clear it. We will clear it and we'll restart. Hold on, everybody. All right, we're restarting. So Wash U is A, Jacksonville is B. Now open, and we'll give it a minute. Looks like we're tapering off in the votes. We'll give it another few seconds here. And the winner is Team B, Jacksonville.
Congratulations. All right, so we have one more semifinals case. This is going to be UT Southwestern against Bellevue. And we'll have Nicole Elliott come on, and Dr. Elliott, if you are in the crowd, hop on up and tell us what we're about to see.
So up next is the paper simulation or paper doll sim. Essentially, on the screen, you'll see 3 patients or quote paper dolls.
Nicole, you're breaking up pretty bad.
Is this better? Okay. So on the screen, you'll see 3 patients, which are the paper dolls, as well as separate pieces of equipment. And basically what you see is what you get for the equipment. What's on the screen is what's available to use. And you have to apply those pieces to the paper dolls as you work through the cases. And there's essentially like an ideal way to solve or complete the cases using the equipment for the appropriate patients. The background is it's a truck driver driving a soybean truck that crashes into a farmer on a tractor spraying a field. And there's a bystander who's the farmer's wife who calls 911 and comes racing out to the scene to help. She also happens to be pregnant. So you'll see how this kind of unfolds.
All right. So the first team to go is going to be UT Southwestern.
Okay, so you are all a bunch of high-speed EM residents going into EMS fellowship, and you are driving in the country and you come across this scene. Traffic has stopped. The volunteer small-town fire department has managed to pull a few patients out of vehicles, and they have them lying on the road. And so you, because you're so high speed, you have a trunk full of equipment. So what you see here is what you have in your rig. You have nothing more. These are your patients to take care of. Oh, sorry, I got one more thing. Sorry, I grabbed it. This is a little visual cues here. Patient number 1.
Are there videos for every patient or just that one?
We got 3 here.
Are they okay? Oh, I feel like I had My chest.
That's patient number 2. And then patient number 3. It's still with audio.
Yes, that's me. I'm the one who called 911. I ran out of here as fast as I could, and I saw my husband in that truck. Oh, but wow, I can barely breathe now. I shouldn't really run when I'm 30 weeks pregnant, right? Oh, but my stomach doesn't feel so good.
All right, there you go.
So each of us is split up into a primary survey on each one.
So real quick, is the scene safe? Are we in the road or are we off to the side of the road?
You're in the middle of the road. Traffic's blocked on both sides by fire trucks and the truck that's tipped over.
In a generally safe location?
No cars are going to hit you.
Okay. And do we have an EMS crew there with us?
You have volunteer firefighters.
Volunteer firefighters. Okay, and they've got the basic materials typically, like IV access and stuff like that.
They don't have anything. You have all the equipment, what you see on the screen.
We have all the things. Okay. Yeah, I think we should split up. Just based on triage acuity, I would say probably 1 and then 2 for both of those. So why don't 2 of us take the first one? How about me and Emmy take the first one and you 2 take the other 2?
Okay, sounds good.
So patient 1 on the left is going to be our first kind of triage. If we can get vital signs on all 3, preferentially person 1 first, and work on access for person 1.
Okay.
As well as.
So you have a single monitor, so you're going to put it on patient 1 to start?
Sure.
Blood pressure on patient 1, 82/46, heart rate 107, respiratory rate 33, pulse ox 80%.
80%?
80%.
Okay. So I'm going to place an IO in this patient.
You've already have an IV.
Already have an IV. Okay. Do we have access? Do we have access to blood products?
You didn't bring it in your trunk today.
Wonderful. Let's go ahead and tourniquet that extremity that's bleeding. It looks like we have fluid. Let's hang a bag of fluids and call 911 for immediate transport to the nearest trauma center.
911's already been called.
Is his airway okay? Is his airway intact?
There is blood and fluid accumulating in the oropharynx.
Okay. Is he awake?
Don't know. He's gargling.
Gargling. Okay. Do we have suction there?
You do not.
Okay, let's go ahead and take that gauze and try to dry up some of the oral materials and see if he's able to ventilate on his own. If not, when we look in the mouth, what do we see?
You see a large gear shift through the maxilla going all the way through the mandible, and you can't bag because of the gear shift.
While you're working on his airway, can we go ahead and assess the other 2 patients?
Yeah.
Okay.
Sure.
For patient 3, can we go ahead and do assess for airway or breathing signs while they're working on airway for patient 1? Get a set of vitals.
She's stridorous and wheezing.
We're going to crack the one. So for patient.
Any vital signs?
Yes, please, for patient 3.
While we're doing that, we're going to prepare to correct patient 1. Most likely, if we wiped off the blood, is he still gurgling and still kind of mumbling and not responding to us?
He's still gurgling and not responding.
Okay.
Can we take a quick look with the video laryngoscope?
You want vital signs for patient 3?
Are you going to so you're going to move the monitor from patient 1 to patient 3 to get vitals?
No.
Okay.
Keep that. We'll just assess.
Then you
when
get a
you
heart.
attempt to place the metal blade into the mouth, it clanks against the metal of the gear shift.
Okay. Yeah, let's go ahead and crike patient 1. Let's assess breath sounds right before we crike. Make sure he's got bilateral breath sounds, and then we'll go proceed with the crike.
Breath sounds bilaterally. Crike proceeded.
Okay.
All right.
Bag him up.
All right, so he is correct. All right, and you're bagging him.
For patient 2, can we just quickly listen to his breath sounds to make sure his bilateral breath sounds?
I don't feel so good.
For patient 3, you said we have stridorous airway, and then do we have bilateral breath sounds?
You have wheezing.
I have
very little air movement.
In both, or one specifically?
In both.
Okay. Can we turn on her left side and help her make sure the airway is clear? What if she looks like that, I guess?
Did our tourniquet stop the bleeding on patient 1?
Yes.
Okay. And we have a EMS crew who is dedicated to bagging that patient until we get them better transport?
You have a firefighter who knows how to squeeze a bag.
Perfect. Okay.
Can we recheck vitals on him?
You patient 1's vitals?
Patient 1's vitals, correct.
82/46 blood pressure, heart rate 55, respiratory rate 14, pulse ox 93%.
Do we know if patient 2 has bilateral breath sounds?
He has bilateral breath sounds.
Okay. For patient 3, can we feel pulses on 4 extremities?
You can. They're faint pulses. Heart rate is about 40 right now.
Rate is 40. Okay. Can I hear? What do I hear on my cardiac exam?
I'm sorry. Heart rate is 140, and your cardiac exam, you hear tachycardia.
Okay.
So we're going to be running all 3 of these patients at once, but we're gonna do one at a time, but as if they're in sequence, since we can't talk to different people at once. So we're going to finish up patient 1 real quick. We'll do a quick reassessment. ABCs. Airways intact. We've got a correct in place. Bilateral blood sound still. We should have kind of stopping of the bleeding with the tourniquet. Any other obvious injuries?
No other obvious injuries.
Okay. And we'll hang a second bag of fluid for him as well. He'll be priority transport to the nearest trauma center.
Okay.
Do we want the pads on?
Okay.
Okay, so let's move on to the stridorous patient, patient 3. Go ahead.
So we said her airway is clear. She has bilateral crackles, and she has weak pulses peripherally, and her heart is 140 for her stridorous airway. Does it look like there's any swelling in her airway? Can I look in her mouth?
Yes, there's a lot of swelling.
There's a lot of swelling in just anywhere preferentially, or it's just under her oropharynx.
The oropharynx.
Okay. So she's is she? Can I ask her? Does she have any allergies? Was she involved in this accident?
She's allergic to soybeans. She was the caller of 911. She was not involved in the accident.
Can we go ahead and get an EpiPen ready as the truck had soybeans in it and she's allergic to soybeans? And can we go ahead and give her EpiPen in the anterior lateral aspect of her thigh? And then can we go ahead?
Epi's given.
Okay, can we monitor her?
Or you can take the monitor off patient 1.
No, I'm just gonna watch her.
Okay.
See if her airway, and then reassess her, see if she's breathing a little bit easier.
It's unchanged.
Okay. And then do it. We don't have any like $100 there.
Do we
Can
start
go
it?
ahead and get an IV on her.
Okay. IV's in.
Do we have multiple doses of epinephrine?
You have that one EpiPen.
Okay. In 3 to 5 minutes, what's our reassessment of the airway?
Okay.
If the 3 minutes has passed and you're reassessing, it's still swollen and she's still stridorous and she's having a very difficult time breathing.
Okay, so we're gonna have to take care of. Yeah, so can we go ahead and get supplies ready to tube her? I want to have a bougie ready, an ET tube. I want to look with the fiber optic.
You can't pass a tube. There's too much swelling.
Can I pass? I can't pass a tube at all.
You can't pass anything.
We'll go ahead and prepare to crack her as well.
So you want to use the scalpel from patient 1?
Do we have a second scalpel?
Nope.
We only have one.
Yeah, just do it.
So yeah, we'll go ahead and use the second scalpel.
And we're going to explain this to the patient as well.
Yeah, prior to doing
And any family members that are around. What we're doing.
All right.
And
so as you're preparing to crike her, EMS shows up in their rig, and they have all the toys of an ALS rig. So anything else that you want to do for these patients in the last minute to wrap up here? You can use kind of any EMS equipment you'd expect to have.
Can we redose her epinephrine?
Okay. Second dose of Epi's given.
Second monitor on that patient as well.
Sure. Monitors on her then.
Okay.
For our third patient, can I just quickly do like a bedside focus on echo on him? I just want to look at his heart, make sure he doesn't have like a large pericardial effusion, and I just want to listen to his heart to make sure he doesn't have a murmur.
Okay. So
Maureen,
we're not going to tell you any results at this point, but you'll do an echo. That's fine. Anything else? You got about 10 seconds.
Okay, and then make sure bilateral blood sounds on the third patient.
Yeah, he does.
Okay. The third one.
Yeah, he has, but can we reassess the airway on the? Oh, go ahead.
Any other EMS equipment you'd want to put on anybody? Any other last minute interventions?
Can we put monitors on
Blood.
the other two patients?
Blood on patient 1 as well.
There's no blood. It's an EMS rig.
Can we get set of vitals on the other two patients?
Okay, vitals are obtained. We're going to call time.
All right, judges.
Wow, this was super hard. UT Southwestern, how did you guys feel reliving this experience?
I think the hardest thing for us was kind of taking care of all 3 patients at the same time in a virtual setting, because if in a real setting, we would all be able to split up and assess our patients at the same time, but because all of us couldn't talk at the same time, it took us a while to figure out, okay, how are we going to split this up so all of our patients get their ABCs assessed quickly. So we found that pretty challenging in a virtual sort of setting.
Yeah, I think our initial plan of like, okay, 2 people take patient A, and then we'll the other people go B and C. Like that initial plan just doesn't work in a virtual setting, and that was a little bit tough to having to like. I think we realized that halfway through, like, oh, we have to regroup. So yeah.
Yeah, I think this is like the oral boards on steroids, you know, like it was really, it was really crazy. So how did you just walk us through, like, how did you guys like kind of triage what was going on? You know, these were all pretty sick people. So how did you divide your resources? What was your thought process?
So the first patient, because they were having active, we would still have like, you know, luckily we're still awake and like they were correcting their airway at the time, but they had like active bleeding, like needed active, like, you know, emergency interventions. Patient 2 was walkie-talkie. He was gripping his chest, but he was, you know, walking and talking. And then patient 3 was also walking and talking. So in terms of like immediate triage, patient 1 and immediate interventions, and as soon as he was stabilized, the idea was to go to patient 3 who seems more stridorous and seemed more like in respiratory distress. And so she was our next person, and then patient with the second patient was our third priority.
Yeah, I thought it was really hard. Obviously, like you had to constantly reassess the patients, and this lady in the corner is like pregnant and she's having stridor. So great job. I really enjoyed the communication and the constant reassessment. And like even though you were on one patient, you actually kept on going back and reassessing one. And even though you wanted to monitor, you were like, no, don't take it off of one. So really hard case. Great job. Really fun to watch. I hand it off to Dr. Griswold and Dr. Elliott.
So again, I don't know how we got on the doctor thing too, but I'm sharing everything. It's all cool. But I actually think I don't really have a tremendous amount to add. I'd actually hand it over to Dr. Elliott and let her tell us a little bit about all the learning objectives that you have, right? Because this is so unique. First, I just want to say that I will really help anybody if you guys want to write this up for the simulation, the education and training journal, because this is really an amazing day. It's an amazing day. You guys are so talented and so creative. It is amazing. So with that though, I'll let Nicole take it away and just, go over the learning objectives, the resources, right? Because I'm sure everything on that page has a meaning, right? So it'll help us, I think, as we're debriefing both teams.
Thanks, Dr. Griswold. So yes, as you saw, there was essentially 3 patients, 4 if you were paying attention very closely. And there was a limited amount of resources, and there was kind of an ideal way to use them. So patient A was to get the cry because you couldn't ventilate and couldn't oxygenate. Okay. They were supposed to get the tourniquet for the circulation, which you did promptly, and some IV fluids. An IV and IV fluids. And then they actually were the patient that was supposed to get the atropine. If you noticed, there was a pool of urine and diarrhea, and they were the farmer that was spraying, so they would have been exposed. But I loved how your team checked scene safety in the beginning. Okay, so that was a highlight. And then patient 2 that on the screen was the truck driver and actually had an MI. So had you asked, you could have gotten an EKG from that monitor, and there would have been evidence of an MI and some bradycardia. And that patient would have needed to be transcutaneously paced. And you could have used the echo too on that patient. And then patient 3 required epinephrine ×2. So you actually did not need to Criker necessarily, but it was an option because you could reuse the material, but you could get a second dose of that epinephrine out of that EpiPen, and then she would have improved. She required IV fluids, and kind of bonus points for if you got fetal heart tones using that ultrasound. Okay. And then, whatever you kind of asked for from EMS would have been great, whatever finishing touches you wanted for each patient. And you guys did a good job of asking about the allergies and assessing right away that this patient was in anaphylaxis, that kind of third patient, and, asking for that echo, recognizing there might be something cardiac on that second patient right at the very end. So great job. Tough one.
All right, great job, team. And up next, we're going to have NYU Bellevue.
All right, you're all a bunch of gung-ho EM residents who are looking forward to your future EMS fellowship, and you're driving in upstate New York when you come across this scene. It's a car accident on the highway. The local fire department is on the scene, and they have pulled out 3 victims from the scene who are lying on the ground in front of you. These are your patients.
think okay. I feel like I had my chest.
Yes, that's me. I'm the one who called 911. I ran out here as fast as I could, and I saw my husband in that truck. Oh, but wow, I can barely breathe now. I shouldn't really run when I'm 30 weeks pregnant, right? Oh, but my stomach doesn't feel so good.
All right, and because you're high-speed EMS, these are all the devices you happen to have in your trunk. You're ready to go.
All right, awesome. So since we get 3 patients, I think that we should split off in terms of how we're going to treat them. So I will take patient number 1. I will take Hannah with me. Rachel, do you want to take patient number 2? Sure. And Charlotte, do you want to take patient number 3? Yep. And then Hannah, you're going to float between them, okay? Good. Okay, so for patient number 1, I would like to get some vital signs.
Vital signs.
Okay, you want to put them on the monitor?
I think we should put a tourniquet on as soon as possible. Sorry, I agree.
Tourniquet?
I'd like to tourniquet that leg, yes.
Okay.
And just mark the tourniquet on time.
Yep.
I'm floating around. Can I ask the third patient if she has an allergy? Any allergies?
Yes, I do. Soybeans.
Give her so we know this. Yeah, we know the truck. It's a Sunny truck, so she might be interfloxing. We're going to give her and we should also get a set of vital signs on her if we can.
Okay, so I need you to speak up a little louder. I heard EpiPen, so we're going to give her an EpiPen. Vital signs, you asked for them on patient 1, but haven't gotten them yet.
82/46 the blood pressure, heart rate of 107, respiratory rate of 33, 87% O2 set. That's what you got.
Okay.
And you only have 1 monitor, so if you want vitals on patient 3, you have to move your monitor.
We put the monitor on patient 3 just to assess vital signs post EpiPen.
Okay, so she's getting her vitals.
While those vitals are going, can we give patient number 1 some oxygen, get some large bore IVs in him, and if we have blood available, start giving him blood?
You are not carrying blood in your trunk. You have 3 liters of LR, though.
We can give him a liter for now.
Okay, and your vital signs post EpiPen are a blood pressure of 80/35, heart rate of 140, and SpO2 of 89%.
Okay, can we also give her a liter of LR? And is that our only EpiPen?
That is your only EpiPen.
We've used it. Okay.
Do you want to put her on left lateral to keep it as?
Okay.
And then for patient 2, can we get vital signs in him as well and an EKG?
Oh, nice.
Okay,
I'm
so you
lightheaded.
take the monitor off of her. Is that what I'm hearing?
Yeah.
Yep, okay. All right. There's your EKG for patient 2.
Can we give him some aspirin 325, put an IV in? Medication.
I'm so lightheaded.
All right. You have no aspirin with you.
Okay.
But
What's the medication next to the calcium chloride? It's just really small.
Sodium
bicarb.
Sorry, did patient number 3 just syncopize, or did we just put her in left lateral?
You put her in left lateral DQ.
I think patient number 3 needs to be intubated. Let's put the monitor back on her and let's get ready for intubation. Hannah, as a floating person, you can intubate her however you feel comfortable. Okay.
You're unable to see cords.
We'll see cords. Okay. Yeah, and the video.
Okay, so
I don't have the
you're
scalpel.
still unable to visualize cords.
Okay, so I'm going to go to Craig. So I'll need the scalpel and the Craig too thing.
Okay. She has been correct.
Right.
I don't feel so hot.
80/35, heart rate 100, 92% while being bagged.
Right, so she's good shape. We can give her another liter. We only have 1 liter left, so we have 2 hypotensive patients.
Your leader's still hanging. It's still running.
Still running. Okay. Which one of the patients is moving?
2.
I feel like I'm going to pass out.
Okay, can we give him a liter?
Let's get the vitals.
What's that?
All right, so you're taking
let's put pads on him. Pads on the chest pain guy.
Yeah, agree.
So
All right.
his heart rate is in the 30s.
Okay, let's give him atropine. Let's get pads on now. We'll give him the atropine.
Okay. Atropine's in.
Can you repeat our heart rate?
There's no change in your heart rate. It's still in the low 30s.
I think we need different pacing him.
Can we transcutaneously pace him right now?
What rate?
70.
Okay. He is being paced at 70.
Which is what?
Someone vomiting?
No, that's me feeling those shots.
Okay.
They asked for your new vitals on you, Ernesto.
He's paced at heart rate of 70. His blood pressure is now 100/60.
All right, we could go back to the first guy and see how he's doing. Question, is there like a spike through his neck? Where on physical exam, what does it look like?
You see what looks like a gear shift that exits his maxilla and goes through his jaw down through his tongue to exit the submandibular.
Looks like that.
There's that extending neck hematoma in him with that. Can we examine his neck and his airway?
You hear gurgling, you see blood exiting the mouth. He's moaning less.
Can we put the monitor on him and then prepare to intubate him? Use the crate on her. Okay, so we still have our tube.
Well, no, because we have this airway device.
Yeah, so we still have our tube, right? Okay, we'd like to move over. We might take
Brief spot on my email there, never mind.
Okay,
All right, so what are you going to do with him?
We'd like to intubate him if possible, assess to intubate him, and get him on the monitor if we're ready for intubation.
How are you intubating?
We're going to try to look from above, since
the blade clunks against something metal in the mouth.
I mean, we could take the scalpel. Yeah. I just use the regular UT tube. Oh, great. Okay, so then we can use the scalpel and we can.
What's this? Do we not use this purple thing? No. Is this purple thing for the crike?
That's an oral airway.
Oh, never mind. We can crack him. Yeah, since you're so good at this. Yeah, crack him too. we'll keep this a regular day.
So you're going to reuse your scalpel and use the ET tube. Is that what I'm hearing?
Wipe it. I'm wiping it. Disinfecting it. Alcohol somewhere.
All right. So you have successfully placed an endotracheal tube in his neck.
Another bag.
You have one BVM. And you have 2 patients. Just so you're aware.
Ooh. Okay, can we put them next to each other and just like switch off as best we can?
Sure.
All right, I think we should reassess all of our patients. So our woman who's pregnant, how is she doing?
She's stable.
She's stable. Do you want to the baby real quick and just see if?
And what are we gonna do? While you do that, I'm gonna call for help and make sure we're getting cars coming. We need people to call the ambulances.
The volunteer fire department's like, yeah, we called 911. They're coming. I don't know if that's how they talk in upstate New York. Probably not. All right. Ultrasound a baby. We're at 10 minutes. Okay. EMS shows up. They have a rig full of toys. Is there anything else you would like to apply to these patients that you haven't done already?
Oh, ALS arrived. Okay.
Yeah, you have an ambulance full of EMS equipment. What else do you want to do to your patients?
All right, let's just go one by one.
So I heard aspirin and calcium in a second bag and your sodium bicarb. So you got your second BDM, you got your sodium bicarb, your calcium, and their aspirin. What else?
Great. So I want to monitor everybody.
Okay.
Repeat a written strip on the chest patient.
All right, you got like 10 seconds left. What else do you want?
And for the guy who's getting paced, we can give him some like sedative so he feels a little bit better. I think they have.
Okay. Time's up.
Yeah, we're happy.
That was fun, huh?
I love the comment at the end. That was fun, right? No. NYU, how was it? Sharing BVMs between patients. How's it going?
Just a regular day.
Just a regular day.
Everybody. I think our biggest challenge, or my biggest challenge as a team leader initially, was that I had another senior resident and had them go to the other patient, but in the simulated environment, it wasn't really possible for us to run 2 traumas at the same time. So to have it organized that we're going through each patient while trying to triage the critically important actions, while also having it happen simultaneously was difficult. But actually watching again, I think we did a really good job at doing that. And I think we were able to assess the patients pretty promptly and get at least critical actions done in a timely way.
I loved your reassessment between the patients as you were toggling between the patients. I know we ask this all the time. If you could take back the time and do it all over again, what would you do besides like wiping the scalpel and reusing your scalpel and all that stuff? How would you play this differently?
Well, I'm really excited to learn about this new epi double dose trick. That's huge.
YouTube, check it out.
Yeah, and I think I mean, I think we did a good job doing the critical actions. I think just like focusing when we're on each person, just making sure we have ABCs before jumping to the next person. And also it just like brings up the importance of knowing exactly what materials we have. I couldn't really see all the things that we have. So just knowing your equipment is always relevant.
Yeah, I thought it was a great design in just having limited resources, especially where we work. You know, NYU Bellevue, Kings County, same, right? So really great case. Thank you. Pass it on to Dr. Griswold and Ellie.
Yeah, I mean, I would just echo that, and again, let Nicole do a lot of that medical management. I do think that you know, you did your reassessments. You know, certainly, I think the only difference this time is perhaps the guy with the MI ended up getting the atropine, but we didn't know his heart rate was 30 before, and you know, we don't really know if there's organophosphates on top of a soybean allergy, on top of all these very complex medical management components of this case. So I will turn it over to Dr. Elliott. And again, I really think this needs to be written up because it's an amazing learning space. So thank you for putting this together.
Thanks again, Dr. Griswold. Yeah, NYU, great job. You actually did right in the end get to like the fourth patient. So pretty amazing. You're right that when you're running a multi-patient encounter in a virtual setting, it's much harder than doing it on stage in Simwars. And I think one of the highlights was you guys were very kind of quick to act. You recognized kind of part of the game of this and just, you know, moved the equipment, acted quickly, and you made decisions quickly, and that allowed you to get a lot of the critical actions for patient one. You applied a tourniquet, you gave IV, you started BVMing them initially and then ultimately ended up cracking them like a little later, but still got to it. Patient two, you recognized that that there was pads and the atropine didn't work, and you transcutaneously paced. You also recognized that you could get an EKG off of that monitor. And you quickly assessed the patient number 3 for allergy, like immediately reacted with the epinephrine, and did several like reevaluations of that patient. It's great that you learned about the second dose. Ultimately, if you didn't give the second dose and should need to be corrected, you did that, and then you even moved the patients close to each other to share the BVM, and like finally, you know, checked on baby to see if there was cardiac activity, and you know, asked for monitors from EMS. So one of the things that just kind of both teams missed was just like the kind of giving atropine for the possible anticholinergic, but in the farmer, but really nice job. It was like a pleasure to watch both of these cases. Thank you for participating.
All right, so we are going to open up voting as soon as Chris says jump. Are we ready to go, Chris?
Yeah, we are. Good.
All right, so if we can have UT Southwestern and NYU stay with their videos on. We're going to open up voting. Team A is UT Southwestern and Team B is NYU Bellevue. So A, UT Southwestern, B, NYU Bellevue, and you should see the QR code on your screen.
Got the votes coming in. Give it a couple more seconds. All right. And the winner is Team A, UT Southwestern.
All right. So for the last case, congratulations to UT Southwestern and UF Jacksonville. Can Jacksonville turn on their video as well? And what we're going to do for the finals is UT Southwestern and UF Jacksonville. We're going to go into a breakout room. And in our breakout room, we'll give kind of a lay of the land.
Tell the audience what we're doing.
How the finals is going to work.
You want me to tell them? Yeah.
Whoever, Camels, you can stay muted. While we're in the breakout room, we're going to have Camels from down in Tampa, our host simulation center, tell the audience what's going to go on. And then we'll do a virtual coin flip in our breakout room. The first team is going to come back. We'll do the live case for the audience. And Chris, it says that Jacksonville can't open video. Can you make sure that they have access to turn their video on? The second group's going to stay in quarantine. And the second group will come in and they'll do their case. We'll debrief and the judges will vote on the winner. So I think that Maurice was going to put us into a breakout room. Maurice, if you're still on the call. And if not, breakout rooms. And if you're going to sit there and spy, then that's great. So I guess we can get started whenever Camels is ready.
Ready when y'all are.
Really quickly, do we still have 8 minutes for this case?
You sure do.
That's correct. And Dr. Caro, can you just turn off the video for Jacksonville?
I can, okay.
All right. So Chris and I are going to jump off and we'll leave UT Southwestern with the Camels crew. You're all set.
Hey, are you guys there? Can you hear me?
Hi, yeah, this is Dr. Jared. I've got a couple other doctors with me. What's going on?
I've been on hold now for almost an hour. I passed out. I called the telehealth service. We've had terrible weather down here, and I don't know if it's my internet connection or what, but I've been having a really difficult time getting through to a doctor. You know, I finally just gave up and did what the on hold music said to do and call 911 because I didn't feel safe driving in this weather.
Hey, sir.
Oh, hey, I'm so glad you guys came. Hey, thank you. I called 911 and they're here already, so I guess we're good.
Well, what happened? Maybe we can help out.
I woke up on my kitchen floor.
Just gonna put you on monitors.
Oh, okay. That's fine. I woke up on my kitchen floor. I don't remember anything of what happened. I guess I passed out.
Did you feel anything before you passed out?
What was that?
Did you have any symptoms before you passed out? A bad headache, nausea, vomit?
I don't remember anything about it, to be honest with you. My head hurts a little bit. I think I might have fell when I hit my head. I woke up in my kitchen.
Hey guys, can you get just some initial vitals? Figure out what's going on?
We can get some vitals for you.
We'll get some.
Work on it. We'll hook them up here. Get my
Glucose on him.
a glucose. Yeah, we'll do a glucose.
Yeah, we'll get
fine.
that for you. He's in sinus right now.
All right. Let's see here. We'll poke. Ow. Sorry. The glucose is 155. Is that normal? Is that good? Yeah.
Let's get started on an IV after we finish our vitals.
Do you want an IV?
Yeah.
Get my stuff on here.
Really quickly, but we're gonna take good care of you, okay? I don't want you to worry. We're just working very fast. We want to make sure you're okay.
I'm just really confused.
Okay, can you tell us your full name?
Yeah, my name is Christopher Struther.
Okay, where are you at right now?
I guess I'm in my office at my house.
Okay, you know what month it
This is where I live, yeah.
is? Hey guys, is he moving all of his arms and legs okay? Like,
Hey sir, can you move your arms and legs? Yeah.
Yep, he's doing
I can
great.
move
Yeah, he's doing
everything.
great.
I can move everything fine.
Yeah, I think we can
Yeah.
take it from here,
Yeah,
guys.
we got
That's,
it, guys. No
that's all right.
worries.
Can we get an EKG before you guys go?
Yeah, sure.
Yeah, sure.
You got the
All right,
monitor already on?
we got him hooked up right now. Just printing it out.
And if y'all can check his pupils for us as well, please.
Moving your eyes.
out the
You get my
EKG
light in.
just now
Yeah, it
for
looks,
you.
pupils are reactive and equal.
Oh,
Yep. Ooh, that looks like maybe a STEMI.
I think we got a STEMI, guys. I'm gonna call dispatch.
I don't feel so good, guys.
What's going on? Oh, he just passed out. I think, sir, I'm not, what's going on, sir? I don't think he's breathing.
Okay, does he have a pulse?
I think I might feel a radial, maybe. I don't, do you feel
trying
anything?
yeah, I'm up in his neck. His carotids, I don't know. It's kind of weak.
I don't
feels a little bit
feel
weak right
anything
now.
there. I think we might not have a pulse here.
Yeah.
If you don't start chest compression.
All right,
You want us to start CPR? Okay. All right.
Someone else who's not doing compressions, place the patient on.
Getting hooked up.
All right, guys, where are we at right now? Who's doing what?
Doing some compressions. We're starting to, I'm grabbing my ambu bag.
Looks like he's in sinus right now.
Okay.
That's cool.
Oh wait,
What? It doesn't look like sinus there.
Wait, what is that?
I think that's
It's a
VFib.
little,
Or VFib. That's VFib.
Is that VFib?
Okay, guys, just continue compressions. Let's get the pads on the chest.
Okay.
And then we'll have another person available.
The pad's hooked up already.
Okay. Is someone back?
Okay. Are we ready for a pulse check? And on that pulse check, let's see what it shows in the monitor. I'm gonna keep.
Okay. I don't have a carotid pulse here.
Okay. Don't have a pulse. What do you see on the monitor?
Pulse. It looks like it's
What do you guys want us to
VFib.
do?
Okay. Let's
Resume compressions and go ahead and charge the defibrillator.
Want me to shock him? It's charged.
We have a charge. You want to shock?
Yes.
So let's clear.
Shock.
Clearly shot.
It looks like he's.
Looks like
normal.
it's in sinus now.
Okay, just continue compressions. I see that you're doing compressions, so continue.
It's getting really hard to bag this guy.
Okay.
Whoa.
Just get
Aaron.
Make sure that we're going at least 2 inches deep on the chest at a rate of 100 to 120 per minute.
Yeah, I can't get any air. He's not breathing really well.
Looks like he's breathing a little bit on his own now.
Yeah.
Pulse check time.
Okay.
Let's do a pulse check.
He's moving a little bit.
Okay, pulse check.
Awesome. Pulse. He's got a pulse and he's normal sinus, it looks like on the monitor. Well, he's sinus tach, like 100s.
Okay.
Air complex.
I still can't get any air through.
Okay. Right. Is he back? Okay. What are our airway supplies that you guys have available?
It doesn't look like we're getting any chest rise.
There's no chest rise. We're bagging him. We can't get any air.
Okay. Do y'all have an LMA or can you intubate?
Yeah, we do.
He's still in sinus.
You don't know, Meg. You want to put it in?
Yes.
Yes, please.
Make sure you follow it all the way through so it doesn't flip on you.
There, LMA's in.
Inflate it.
LMA's inflated. Okay.
Can you
Bagging well now.
Okay.
Great. Okay. Let's get an EKG.
Okay, we're gonna go to the EKG here.
Yep, we're gonna run the EKG.
Okay. Looks all right. Got an EKG here. About the same as before there.
Like a Sprugata.
Do you want us to call the SEMI out?
Yeah, you know what? I'm still not getting any air in. It's just I just lost it. It's not going in.
Oh, that you're not getting air?
Air's not going in. Air's not going in at all.
Okay. Do you have a scalpel and are able to crike?
We don't have a scalpel, I think.
A laryngoscope so we can intubate him?
We have a laryngoscope. Yeah, we can intubate.
Let's go ahead and intubate.
10 seconds.
All right. Okay.
And call it out so we can get him transported to a hospital as soon as we can.
Right now. You want to inflate that cuff for me, buddy?
And time.
All right, we can have our judges come back up to talk about the case.
Are we doing it all at the end again? Or are we?
No, we're gonna debrief this group now so that Camels has a chance to reset.
Okay, my apologies. Well, I'll start off then. So how was that experience?
It was pretty tough. Difficult communicating with the folks that were in the room. I think we would have benefited from kind of clarifying a little bit early on what the available equipment was with our EMTs so that we knew what options we had available to us. It was difficult to get an assessment of what the issue was with the patient's airway. If it was difficult to bag and concerned that we were missing an etiology that we weren't able to address in the time that we had. But certainly a challenging situation trying to provide telehealth to other providers who are hands for us.
So if you were going to describe or predict what the learning objectives were for the case or what they really wanted you to get out, usually we do the kind of the summarize the case. So if one of you would be willing to summarize the case and kind of give us your feel for what you think you were supposed to get out of the case, and then I'll turn it over to our other judges.
So initially we got a call from a gentleman. He was just concerned that he wasn't feeling very well. It sounded like he just felt a little confused. He passed out. We weren't able to do like a very quick trauma survey to see if he like injured himself when he passed out, but we did try to assess the medical reason for why he may have passed out. So we asked if he was feeling dizzy or short of breath or nauseated prior to passing out. In that time frame, EMS came because he had called 911. And after EMS arrival, we quickly checked a D-stick. His blood sugar was normal. And then as we got the EKG, we recognized that the EKG was not normal. It looked like it might have been Brugada initially. We got a quick glance, but in that time frame, we then lost pulses, so we started CPR. Initially, he was bagging, and then he wasn't bagging very well, so we decided to put in an LMA. And he was bagging fine with the LMA initially, and then he was difficult to bag, so we decided to go ahead and intubate. And after that, we were able to get ROSC and a repeat EKG. Well, we were not able to get a repeat EKG, but the initial EKG, we looked at it again, and it did show a Brugada pattern. So we decided to activate a STEMI and transfer him to the hospital.
Fantastic, courageous work.
I think that's a perfect summary of the case. You guys identified all the major points of that case. It was a Brugada case, obviously with syncope. So kudos to you. That was really difficult. Telehealth, not easy. Obviously something we're all dealing with in COVID-19. And kudos to Camels for simulating this Zoom glitch, SIM glitch. I mean, that's totally something we would generally suffer with as well. So very, very true to life case. I have a quick question for you guys. When EMS arrives and they're trying to blow you off and be like, yo, we got this, like, we're good. Like, what, besides this being Simwars, like what got you to keep digging and kind of keep going with the case? Like, what didn't smell right?
We didn't have a reason for his syncope. And someone who was feeling really confused. That's why we also asked for like quick neurological exam, like as the alert-oriented pupils, moving all the extremities. It could be anything from stroke, cardiac, your differential is huge. And so just the breadth of the differential in a relatively young patient who sat there for an hour, like because he really wanted to talk to a doctor, something's wrong. And so we didn't want to let EMS just take the lead without having at least some idea of why he syncopized in the first place.
Yeah, I think that was such a great job to not be blown off like that. It's so easy, especially when you're the teledoc, to be like, oh, I'm busy, like, fine, go take him to the nearest ER. But I think your instincts were spot on to kind of dig a little bit deeper. So kudos, great job. I'm going to pass it on to Dr. Kazera.
Yeah, no, I think Dr. Kim and Dr. Griswold said lots of great things. And again, kudos to such like an excellent job. I mean, it really is quite a challenge. I'm glad I don't do much telehealth, although I got my training and I did my brief little intervention, and hopefully not going back to it, but it's tough. Yeah, I was amazed at the insight that you had from the telehealth perspective to see the procedure that was being done, namely the compressions and then the intubation, and to offer the insight to sort of, be for those providers to be mindful about how they were doing the compressions and how deep they were going and how fast maybe they were doing them, and also the technique about how to do the intubation so well. I thought that was really insightful. What made you, have you done that? Each of you as team members, or what made you think of actually commenting on the compressions or on the airway as it was being done?
Like why I commented on the compression depth and like how fast it would be going. I noticed that his elbows were bending, and it didn't look adequate, and so I just wanted to send a reminder of what adequate compression should be. And I mean, granted, he's one person who could be getting tired. That might be his cue to say, "I'm tired," when he gets switch off, but.
And quality SIM ACLS experience at Southwestern.
No, I mean, it just shows that, the three of you are future simulationists at heart, because you're looking at really high quality performance of a skill that's otherwise very basic. And how many times do we each probably engage in these types of things and see breaks in best practice? So I think just your, the ability, the way that each of you deconstruct tasks like the ones that you saw, even over a video, even though you're not really there in person, you were able to break down those tasks and say, wow, those are breaks and best practice. Maybe we should sort of comment here for this patient's, outcome. And I thought that was a really nice thing to see.
All right, well, thank you to UT Southwestern. You guys can go ahead and turn off your video, and we're gonna have University of Florida, Jacksonville turn on their video, and they can come on back into the room. And once you guys are all positioned and set up, we will we'll start the second case. So. All right, well, welcome back, guys. I'm gonna jump off. You guys can hear and see and everything's happy and ready to go?
Yep.
All right, someone will be with you guys in just a minute.
Thank you.
Hey, finally, gosh, I've been on hold for like almost an hour now. You're the teledoc service, right?
Yep.
Right.
Oh, okay. You know what? I'm sorry. I did what the hold music said. I had been waiting. I mean, it's been, I don't know if it's just connection issues or the thunderstorms we've been having, but I've been on hold for so long now that I finally just called 911 and gave up. I had passed out and, I dialed in. Hey,
paramedics.
hey, thank you guys for coming.
Oh yeah, you're
How you
good.
doing? What's going on?
I passed out. I don't even know what happened.
Okay.
I woke up in my kitchen on the floor. My head kind of hurts.
So my name is Dr. Carrick. I'm one of the emergency physicians. Could you please let us know what kind of led to you calling the paramedics today?
I passed out. I woke up on the floor in my kitchen.
Just gonna put you on the monitor, sir.
Okay, thank you.
What happened before you passed out? What's the last thing you remember?
I was making dinner.
You were making dinner. EMS, could you guys take a finger stick, please?
Oh yeah, of course, no problem.
Give us some vital signs. Okay. Has this ever happened to you before, sir?
Yeah.
No, it's never happened to me before.
Stick here, sir.
All right. Could you guys when you get the vital signs, if you could establish IV access?
So 155 is the glucose there. Guys, I think we can take care of it from here.
All right, I'd like to just be able to talk to the patient a little bit more. What medical problems do you have, sir?
I have high blood pressure.
High blood pressure. Have you ever had anything like this happen before?
No, not that I don't think so. No.
Do you remember getting dizzy or lightheaded?
No, I don't remember. I mean, no, I don't remember any of that. I don't remember anything.
Could you guys run a 12 lead as well while we're talking?
Sure.
No problem.
Sure thing, boss.
What are the rest of the vitals?
Sorry, my head just hurts a little
There's
bit.
130/80.
Have you ever had a headache like this before?
Bring it out. Is that the EKG? No, I don't.
Wow.
I mean, looks like a STEMI.
What's wrong?
This is the EKG right here. I think it's a STEMI.
I don't.
Call a STEMI alert?
I don't
Probably
feel
call
so good.
dispatch
Oh,
over here.
guys, I don't feel so good.
Hey, he just passed out. I don't know what's going on here.
Can you check pulse?
I don't know. I think
I might have.
I got a
faint radial. Maybe is there? Maybe.
no. I got a pretty weak carotid over here.
I don't think I have one. I don't think I have
don't
a pulse
know.
here.
Put him on defibrillator, please cut his clothes off, put him on defibrillator and check a femoral or a carotid pulse.
I don't.
All right, we'll try. We'll do our
I don't have a
best.
femoral pulse here.
I don't know.
CPR.
CPR. Hold on, we're getting him on the.
Getting my hooked up right now.
You do CPR, the other one, you get the monitor ready.
Okay.
All righty. I got it, boss.
So chest compressions are going. Is he on the monitor?
He is.
Related to the AED, if you have one.
Like he's
There it is. Okay.
All right.
Monitor. We're doing compression.
looks like he's sinus right now.
That looks wide. I don't know if
Wait,
that's.
what?
I don't know if
Let me fib.
2 minutes.
I think it's B-fib.
Yeah, it looks like VFib.
So keep doing compressions. I'd like you to charge the Zol to 200.
Charge to 200. Working on it. Okay.
Okay. So I'd like to go ahead and have the Zol charged. And when we get to the 2-minute mark, I'd like for you to pause, do a rhythm check.
Okay. Charge.
Charged.
As I since the last time we checked the rhythm.
It looks like VFib.
B-fib.
All right, clear. You want us to shock him?
And then start compressions once the shock is delivered.
Okay. Shock's delivered.
Boss, I can't get any air in.
Doesn't look like
Yeah.
it's-
There's no chest rise.
Do
Okay.
you have an LMA or any other?
Yeah. Yeah, we have an LMA. Let me grab one of
Looks
those.
like he's starting to move around a little bit here, though.
Okay. Well, we're gonna keep doing compressions until we get to the 2-minute mark.
Getting the LMA in right now for you. I'm inflating the cuff.
Do you have ACLS drugs with you?
Yeah, we have drugs.
Okay. Well,
Yours going a little bit better.
when we get to the 2-minute mark, since the last time we stopped compressions, I'd like you to stop and do another pulse and rhythm check.
If you think you see chest rise, try to breathe a bag with the spontaneous respirations.
And we're gonna go ahead and call another rescue to your location so that way you can have more support.
Where are you calling from? What is your access to roads and hospitals?
Air and he's not,
Doesn't
there's
look
no
like he's
air
dying.
going in.
Yeah.
Okay, do you see anything in the airway?
No, there's nothing in there. I can't get it.
Okay.
Nothing's coming out.
Do you have any intubation equipment?
Yep.
We do.
Let's take a look with the laryngoscope.
Do you have a scalpel also?
We do.
Okay, so I would like to take a look with the direct blade first.
All right, I see the cords.
Okay.
Want me to hit him?
You?
Want me to pause compressions for it?
No,
If you're
you don't
able
have
to.
to.
If you get to the 2-minute mark, stop otherwise.
Awesome.
Got it.
Okay.
Wonderful. Are you able to bag?
He's bagging.
Yeah, he's
pretty
bagging
well
okay.
now, but
I think his rhythm just changed.
yeah.
If
Okay.
you're able to switch compressors.
Want to switch?
Yep.
I'd like you to do, oh, okay. Can we start, just go back on the chest bars, please? Did you happen to see what the rhythm looked like while you were doing that?
B-fib.
Yeah, it looks like VFib there.
So, okay, keep doing compressions, charge the Zol. Again.
Put it to 200 joules when you try.
All right, pause compressions, shock, back on the chest forming. Good. Drugs.
The sinus.
Okay. 2 minutes.
Meanwhile, why don't you push amnio?
Yeah. Do you guys have amiodarone or epinephrine?
We do. We don't have any IV access though.
Okay. Do you have an IO access? Do you have any way to get access? Wonderful. I'm okay with passive oxygenation to get access.
Okay, I got some IO here.
Wonderful. You give a dose of epinephrine followed by 300 of amiodarone.
Okay, I will give the epi. Okay, epi going in. Okay, and then with amio as well.
Please.
Okay,
You're doing great, guys. Keep going. You're doing a good job.
okay, amio's in.
Wonderful.
Up here? Yeah, boss. Come.
Where are you located? Do you have access to another rescue team to get here or transport into a hospital?
Yeah, we can transport to a hospital. Yeah, we can get them there.
Okay, it would be you guys to transport?
Yep.
Have another rescue team to be able to come help you. Obviously, we want to continue compressions. Switch if you're getting tired.
Getting tired.
All right.
All right. Can you switch for us?
We can look up and get them going if you want.
Yeah. At the 2-minute mark from now, we're gonna pause for compressions, do another rhythm check, and check for a pulse.
10 seconds.
Wonderful. I want you to keep bagging. Wonderful. At the 2-minute mark, you can pause. Do we have a pulse?
And time.
We have a pulse.
Interesting.
All right, judges.
Okay, I will start again. So the Jacksonville team, want to give us your initial reactions and thoughts after participating in that case?
Telehealth is difficult. It's difficult to try to know what you have, especially when they crump so quickly like that, knowing what resources to work with, trying to run through that while also going through, the steps of resuscitating the patient.
And like walking through someone else going through the steps, because obviously we knew those steps, but making sure they actually knew what we were talking about. It was definitely a little disjointed at first, trying to like get as much information as we could because we didn't know what had actually happened.
Like it was kind of hard. At first, it seemed like it was a regular telehealth visit, and then the paramedics showed up, and it's kind of unclear if you're supposed to just transport them immediately or dig a little deeper. I guess we just try to get vital signs and IV access established before they transported at least, and then at that point, that's when it went down.
So if you're going to summarize the case for us, how would you summarize the case in a few sentences?
It's a telehealth visit for a patient who had a syncopal event that had been on hold for a while. When probably had some sort of coronary event. They called EMS, went to VFib arrest.
Good. So the EKG, anything special about the cardiogram that was flashed up for you in those brief moments?
I was gonna say it was kind of quick. It looked like elevations in V1 and V2 maybe questionable, like Wellings. It was very hard to like see on our screen. But that's kind of what jumped out to all of us at first.
Again, I really liked the way you guys communicated. It's also in this very unusual environment, right? We have 4 of you on a telehealth visit. So that's maybe why we are having trouble with our resources with telehealth. We have 4 doctors waiting on 1 call. But anyway, I applaud everyone for a spectacular job today, the creators, everyone. So I know that everybody will do those kudos at the end. But thank you so much for your willingness to do this. It's been pretty amazing. I'll turn it over to doctors Kim and Cassara.
So guys, great job. Just to clarify, I don't know if Camus is able to show us that EKG, but it was a Brugada pattern, just to clarify. And basically you did all the right things, defibrillation and resuscitation. And then I love the final decision to transport, but I kind of wanted to touch on what the first leader kind of mentioned. It would be so easy when the EMS guys came to be like, oh, you want to take him? Okay, bye. Like, so what motivated you to keep on digging deeper and say, wait, hey, hold on, what's going on? Like, give us a little bit more information.
Because we have literally nothing. Like, it could be, I have a glucose of like 15 before the transport, and that's something that can be fixed, and so he doesn't crump in the. I just wanted to make but when I saw the paramedics, I just want to make sure he was stable enough to at least get to the rig to be transported. Like I said,
especially with an easy fix like hypoglycemia or anything like that we could fix.
Something we could reverse and make sure they actually get to the hospital on time.
I love you digging deep on your paramedic experience. Were there any other cheater? I feel like, are there any other things you wish if you did this again, you would have checked or thought about besides?
I think the first things I asked for was the glucose vitals and IV access before transport at 12 lead. Maybe I would ask for a 12 lead a little sooner. But What else they could, unless you guys have any ideas.
I mean, potentially have gotten to the ACL strokes quicker, but I don't think it would have changed any outcome at this point.
Especially with just 2 people that were switching back and forth. Obviously, we're trying to do the most important things of getting airway and obviously keeping compressions, especially the bystanders. So, and AD.
Yeah, I definitely think, you know, making sure your patient's stable and like making sure you've covered all your bases. I think the only other thing I would have thought of is probably CNS issues, just making sure with your glucose check, obviously, as part of it. But I love the communication. I love the transport talk, and definitely being so clear about your directions on how to defibrillate. Great job. Really hard to do over tele, but I thought your directions were incredibly clear. Great. Dr. Casera.
Yeah, I mean, again, I just have to echo the kudos from Dr. Kim and Dr. Griswold. It really was remarkable to watch, and again, even both teams. But yeah, your performance in the way that you picked up on some of the things, I'm curious about. There was a moment when the patient arrests, and then I think one of the team members over on the end started doing nonverbal cues about let's get the compressions going, let's get the compressions going, and it was good to see because I think. Well, take me through that moment. I guess if you know, what was it about that moment where that hand motion sort of came up, and because it really did get the attention of the leader. It didn't distract the leader from already sort of making some sort of comments. Yet it sort of was a good cue to say, "Hey, get those compressions going." So tell me about that moment.
Yeah, I was trying to be helpful and communicate with my leader, but without overpowering and interrupting and stopping kind of the flow of the orders that were being given.
I think it's kind of hard to assign roles when there are no roles.
Yeah. There's 4 doctors, 4 doctors.
No, but it's still, you know, it seemed like sometimes there's one person that just sort of moves dynamically into the moment of leadership, and I think it was really something that in that moment, when someone's sort of in that leadership moment, that there are good principles of followership, and to advocate, like several times, each of the other people on the team, if not in the leader position, still spoke up and said something, which or did something, like to sort of get the attention and to sort of prompt the person who was in charge. So I really thought that was something nice to see. And you know, sometimes you can think out loud in an actual resuscitation, maybe when you're all together. In this sort of moment, it was important for clarity to the providers to sort of hear one voice, and maybe in this telehealth virtual world that was a good, effective strategy. I thought that was really something cool. So I wish I recorded that, but no, that was awesome. I guess you know, other things to consider. I know that there did seem to be a good recognition of the ACLS. I'll just put a shout out to the BLS just because we're all here together in the Simwars environment. Like I saw a couple of sort of one-handed compression and an attempt to bag and compress by that operator, you know, on scene, and so you have some moments there where if you're a chance to watch that you are empowered to sort of call the providers out and say, hey, look, I'm not seeing best practice there. Maybe put 2 hands on the chest and maybe compressions trump ventilation, so to speak. You know, in the same way that you mentioned, hey, you know, make sure that when that 2-minute time comes around, got to deliver that shot, got to get that epinephrine, have to cross check on the amiodarone and so forth. All those things you did there were excellent high points. I'd say you're empowered to sort of do those same things when it comes to the BLS pieces, ventilation rates or compression rates as well.
All right. Well, thank you to both teams. So what we're going to do is we're actually just going to have the judges jump off for a minute so they can deliberate. And any of our case collaborators that are still on the Zoom, we'd love to have you guys turn your videos on just so that we can thank you guys. This really is a huge team effort. It takes a community to make Simwars run, and to everyone that contributed, just wanted to give a huge thank you. And we'll start with Camels, and just wanted to let you guys introduce yourselves because you guys made a lot of this happen.
Yeah, so I'll let the team introduce themselves. I'm Haru Okuda here at Camels, and Ryan is the brains behind the case. So Ryan McKenna, I think you guys all know.
Send all your complaints to yakuda@usf.
Yeah. You guys want to introduce yourselves?
Sure. Rishi Rain, PGY1,
And just so you know, I don't do one-handed compressions and bagging in real life. That's just a, you know.
Yeah, I'm Tommy Bloom. I'm one of the third years here, and I'm usually better with compressions. I wanted you guys to say that I wasn't doing them good, kind of.
Awesome. And Colleen?
Hi, guys. I'm Colleen Reiner. I'm the interim director of education here at Camels.
All right, come on.
I'm Phil Wortham. I'm the director of operations here at Camels.
And we have a couple more, but they've all run away.
Awesome. Thank you guys so much. I saw Lars pop his head in for a second, but Jason Wagner from WashU. You want to say anything?
I guess kudos to everyone who did the work, but for you guys for pulling together this virtual Simwars again. I think it's awesome that you guys could not miss a beat and keep this going.
And Nicole Elliott.
Yeah, thank you guys for organizing. It was a lot of fun to be a part of. Thank you, Jason, for leading the way for this awesome case.
Lars.
Echo that, Jason. That was just being part of that case was a lot of fun. I learned a lot, and I think just seeing the teams go through that in the Sim Wars, which it truly is inspiring and cool, and seeing how people put all this stuff together. So nicely done, teams. Nicely done, Simwar teams, putting this all together. I echo that. Just amazing coordination and just pulling it all together in this bizarre virtual world. Hats off.
Thanks, guys. I mean, it really does take a village to make Simwars work. And as of now, we are planning on being all together in Boston for ASAP. For anyone that is in the audience watching, if you want to get involved in Simwars, please send us an email. We're always looking for new folks to help us out, to collaborate, to write cases, to act, to participate. Simwars@gmail.com. Please let us know. We'd love to have you as part of the team. Chris, do you want to say anything?
Yeah, just we will probably start planning for ASAP sometime in late summer. So if you do email us and you don't hear back from us, email us again, because sometimes we can get busy, and doesn't mean we're ignoring you, because we really appreciate everyone's help and always need, especially in person. We're going to need lots of help, because we need people who, not just with case writing, but on that day, sort of logistics, acting out in some of the scenarios. So yeah, it's really valuable. And again, this is a important thing for people who are in academics. This can be a good thing for promotion. I mean, there's a lot of different aspects in this, from case writing. We're trying to look at publications. I mean, we got mentioned at the beginning of the book. So we had in the past, so we have book chapters. So yeah, so this can definitely help you in your academic career as well. All right, it looks like our judges are back. So we will turn it over to
one second. All right. Take it away, team.
So we all had a great discussion, and the winner of the 2021 Resident Simwars for SAEM is UT Southwestern. The overwhelming applause. It was really, really slim margin, but amazing job for the both teams. It was really, really tiny margin, but you guys did such a great job recognizing the brugada and just, calling out the compressions and all of that. So just by a hair, and both of you had such great leadership skills in all of the sims that we saw. Both of you guys do amazing job all day. So yay. Congrats.
All righty. Congratulations to all the participants. Congratulations to UT Southwestern. Thanks, everyone. And hopefully we'll see you in the fall in person.
And UT Southwestern, you have the ability to defend your title at ASAP. So
congrats, everyone.